get started with today's stuff. All right, good morning. Today is Wednesday, December 2nd. We are rapidly approaching the end of the semester, and we have a ton to do. We climbed to the top of our cranial nerve mountain. We need to work our way back downside on that. We've done the first 6 cranial nerves, and we will start with the last 6. Then we have to finish up our spinal cord and then start our autonomic nervous system today. So that is our game plan for today. You have 2 more assignments due, Unit 14 review, which is the review, you know what that is like, but there's also a fun reflex lab giving you a chance to poke and prod your family and friends. Wednesday next week is your lab and lecture exam. So this is your big weekend to study for this and start looking ahead. You have the lecture notes. You know what we're going to be covering. So whatever we don't cover, you should be looking ahead at so that that information is not completely new for you on Monday, 2 days before the lab and lecture exam. You also know how to take a lab and lecture exam. You've done that 4 times, so you know what to expect from that. Oh, excellent. And some people have done it already. That's spectacular. Then you have a week off. We do not have class on Monday the 14th. It is considered part of finals week, so we do not have class, so we don't meet, no new information. I will have my normal office hours, so if there's questions, you can reach me, and of course by email as well. And then 1 week after your lab and lecture exam, you have your final exam. And again, it's basically like a big daily quiz. 100 multiple choice questions, 100 minutes, and covering everything we have covered lab and lecture from this class. Again, you have the entire class time to take it. It must be completed during the class time, and you will have 100 hours. Yes, so yes, I will definitely have my normal office hours on Monday. I will probably have extended office hours on Tuesday because my 431 class has their final on Tuesday. So I'll be dealing with them on their final. So I likely will be on the computer, even if I'm not officially in office hours. If you email me, I will likely be available most of the afternoon on Tuesday because I'll be there for their exam. It is proctored, yes, using all the same format. So yeah, you're right. So it is like the daily quizzes in that it is all multiple choice questions, but it is proctored. You do have to show your ID and do all those things like a normal exam. So yes, that is correct. Thank you for correcting that. All right, and that's the game plan. And then after that, you get to drink heavily or sleep or do whatever else is you need to do. All right. Any questions on the game plan? I don't think there's anything new there. So hopefully that's straightforward. Excellent. Donuts. Perfect. Absolutely. Good plan. All righty. Let us then get back into the cranial nerves. As I mentioned, we did the first 6. We've worked our way through the first 6, so now we need to finish off the rest of the cranial nerves by working our way through 7 and down. And of course, 7, as you can see from the illustration and you know from the name, is facial nerve. Remember, there are 4 things we need to know, name and number. So obviously number 7 is the facial nerve. We also need to know its functional type. What is the functional type of our facial nerve?
Mixed, both.
Yeah, exactly. It is both. It is both sensory and motor. Let's first talk about the location of cranial nerve 7. As you see, like 6, it is located beneath the pons. However, remember, as we talked about 6, 7, and 8, all 3 of those are below the pons, but remember, they're not equidistant spread out from each other. 7 and 8 are right next to each other, whereas 6, remember, sad, lonely 6 is over here by itself. 7 is right next to 8. They're BFFs, and we'll see how that's significant in just a minute. And as the name facial nerve indicates, its primary motor function is to control the skeletal muscle of the face, allowing you to produce your facial expressions. Again, we are very good at emoting anger, fear, arousal, confusion, all of those things with our faces, and it is this facial nerve that controls that. Now, another way you may be familiar with this involves its skull exit. If you'll notice, its skull exit is out of a tiny little hole between this long pointy bump and this big rounded bump. What was the long pointy bump of this again? Anyone remember what this bone feature was?
Styloid process.
Styloid process. And what was the big round bump? Right behind your ear.
Mastoid process.
Mastoid process. So what was the tiny little hole between them?
Sternomastoid foramina.
Yeah, stylomastoid foramen. Absolutely excellent. And if you weren't 100% sure, it actually says it here on the slide. And if you remember when we looked at it, that was a very tiny little hole, right? When we looked at the skull, very, very small, very tiny hole. Right next to the mastoid process. And remember also, while the mastoid process feels big, feels large, remember it is also hollow on the inside and has that mastoid sinus. Why this is significant, and I think we talked about it when we talked about the bones, is that inflammation of that styloid process, of that mastoid sinus, inflammation in that mastoid sinus can actually cause a constriction of that tiny opening, squeezing that nerve. And when it squeezes the nerve, blood's not going to the nerve becomes non-functional. So that now when you try to smile, only one half of your face goes up and the other just sits there drooping and does nothing. Anybody remember what we called that condition or what that condition is called?
Stroke.
Not a stroke, although it is a similar function to the stroke. But remember, stroke is when there's damage to the nervous tissue of the cerebellum. No, it's Bell's palsy. Bell's palsy is that condition. Luckily, usually it is temporary. It can last a few days to a few weeks. In rare instances, it can be prolonged. And if the damage to the nerve is severe enough, it can actually become permanent. And if you remember, I think when we talked about it the first time, I mentioned that there have actually been 2 or 3 recorded cases where the Bell's palsy was actually caused by someone driving a car with the window open. You're driving the car with the window open, the air is blowing by your head. It irritates the sinus of the mastoid, causes that inflammation, and as a result, they got Bell's palsy because they didn't want to use the air conditioner. All right, that is its motor function. But we also here we go, a sensory function. So again, here we see the motor branch where it's controlling the muscles of the face, giving us that expression. But it also has a sensory function. And the sensory function is to provide our taste sensation from the anterior 2/3 of the tongue. Our tongue has a map over the surface of it. And that map basically represents all of our taste sensations. And how many different taste sensations do we have? Anyone know how many different types of taste receptors we have on the surface of our tongue? Which is it, 4 or 5? Well, okay, so let's work it out. Haley's got it. So we've got sweet, we have sour, we have umami, which is that savory sensation. I see salty, and I see bitter. Any others? No. So we have 5 taste sensations. Now, if you go into a kindergarten class, often they will have sensory pictures on the wall. And one of the pictures they like to have on the wall is a big picture of a tongue. And on that tongue, they have a circle that shows that the sweet is here at the tip of the tongue and the bitter's here in the back and the salty's over here on the side. Is that really what it's like? Does everybody have the exact same taste sensations located on the exact same locations on their tongue? No, absolutely not. But we do have taste maps on our tongue. You can actually experience this for yourself. You were actually, yeah, they're totally spread out. You can actually experience this for yourself. You were talking about fun things to do with your kids at home. One of the things you can do is sit around the table with your kids, take a little water, rinse out your mouth, and then take a paper towel and dry off the surface of your tongue. Take a Q-tip, dip it into some sugar water, and then rub it over the surface of your tongue. And as you rub it over the surface of your tongue, you will see that there will be a couple locations where you can taste that sweetness. Then do the same thing with salty water. For sour, you can use lemon juice. For bitter, you can use coffee. For umami, you can use MSG if you're not sensitive to it. The red juices from meat will give you the same sensation. If you're vegan, the juices from mushrooms. If you saute mushrooms, the juices from that can sometimes work as well, although those are a little bit more complex and can affect other areas as well. So it's not just straight umami, but you can get that savory sensation. You can actually do a map of your own tongue in that fashion. So that sense of taste from the anterior 2/3 of the tongue. Notice I keep saying the anterior 2/3 of the tongue. We haven't looked too much at a tongue, so let's do that real quickly. Bet we can do that here. Going to that virtual anatomy website again. And probably easiest to see it, my guess, would be in the digestive system. If we look at our digestive chart, let's see what we have here. There, it's not bad, but there we go. That's the picture I wanted. Notice on the tongue, this is the anterior 2/3. This is where we perceive our taste. This is what we stick out of our mouth. This is what we use primarily for chewing and talking. But the posterior third is actually covered with lymphatic tissue. This is our lingual tonsils, part of our body's defenses from pathogens from the outside world. So it's just the anterior 2/3 of the tongue that we get most of our taste sensation from. There are other taste buds on the roof of the mouth, on the cheeks, and areas along those, but those provide more general taste sensations. Really specific taste sensations really come from the surface of the tongue. And it is the facial nerve that provides us with that information. Notice it also innervates our nasal cavity. Our facial nerve helps us to produce tears and produce saliva. So it has some autonomic functions, and we'll talk about those in more depth when we get to the autonomic nervous system later today. So here we clearly see that this is a mixed nerve. Not only is it a mix of somatic motor and sensory, but also autonomic motor as well. And as we mentioned, we get that nerve to come out right here in that tiny, tiny little opening. You compare that to the size, for instance, of the foramen ovale, or things along those lines. Here you can see it is very, very tiny, that tiny little opening between the styloid process and the mastoid process. We do have one issue, though. How does it get there? If we had tried to put a probe through that styloid-mastoid foramen, do we see the stylomastoid foramen from the inside of the skull? Does anybody remember? Does it go all the way through? Do you see it as we look at it there? There's the foramen ovale. There's the foramen spinosum. I don't see the stylomastoid foramen, and that's because it's not here. Remember, 7's BFF is cranial nerve 8. We'll talk about cranial nerve 8 in a second, but cranial nerve 8 is, what is the name of cranial nerve 8 again?
Vestibular.
There you go. Vestibulocochlear, absolutely. Back in ancient times, and by ancient times, I mean when I was in graduate school, cranial nerve 8 was known as the auditory nerve. In fact, my mnemonic, which definitely is not suitable for work, so I will not be sharing it with you anytime soon, uses A in that mnemonic for that because of the auditory. So it goes to the inner ear where we can hear. It gets there through this opening right here, the internal auditory meatus. And so what actually happens is 7 follows his BFF into the internal auditory meatus and then comes out on the underside. And since what we care about is the exit, it comes out the stylomastoid foramen. So its opening is indeed the stylomastoid foramen, its skull exit, I should say, is the stylomastoid foramen. But here we see how cranial nerve 7 follows cranial nerve 8 into the temporal bone through that internal auditory or internal acoustic meatus. All right. Questions on 7? All right, excellent. Let's go to 8. As I mentioned, it used to be known as auditory, which was nice because auditory was a lot easier to spell. But cranial nerve 8 is now known as the vestibular cochlear nerve. And that's because calling it the auditory nerve was a huge disservice. There are 2 branches to cranial nerve 8 because it provides us with 2 pieces of sensory information. And in fact, if we work our way down our mnemonic, what is the functional type of cranial nerve 8?
Sensory.
Sensory, absolutely. And so, as I mentioned, it's sensory. And it provides us with 2 pieces of sensory information. Because here inside the temporal bone are 2 specialized sensory structures. The first of those specialized sensory structures is this big curly Q snail-shaped structure known as the cochlea. The cochlea is where we perceive sound. So this is where we make sense of our sound information, convert those vibrations in the air into action potentials that our brain can understand. However, notice there is also a second sensory structure in here as well. And that second sensory structure is known as the vestibule. And so this vestibule is what gives us our sense of equilibrium and balance. What do I mean by equilibrium and balance? Well, if I were to put you in the office chair that I am sitting in right now, and I were to spin you around 16 times and then ask you to run to the kitchen, would that be something that would be easy for you to be able to do? No, because we would upset your balance. The same thing with equilibrium. If you're in an elevator with no windows and the elevator starts moving, can you tell whether the elevator is going up or whether the elevator is going down, even if there's no windows?
Yes.
Yeah, and that is because of that equilibrium. As we start to move, you can feel that sensation of movement in it. Even though you can't see it, you can perceive it. So our sense of equilibrium, our sense of balance, our ability to be able to stand up without moving with our eyes closed, all of those things come from this vestibule. So we have 2 distinctly different sensory structures providing 2 distinctly different sensory pieces of information. And so it is much more appropriate to refer to it by those 2 special sensory structures. And that is why it is the vestibular cochlear nerve. Again, as we've talked about many times, there's often these alphabet soup words we have to learn, but typically when we have to learn them, it's for a reason. And here's that reason. The vestibule and the cochlea provide us 2 different types of sensory information. Now, notice the one interesting thing about cranial nerve 8 is cranial nerve 8 doesn't technically leave the skull. Because notice these special sensory structures are inside of the temporal bone. However, it does leave the cranial cavity. And since it leaves the cranial cavity, we will call that opening in the skull that it passes through to get into the temporal bone. That is what we will call its skull exit. So it exits the skull. Well, doesn't exit the skull, but it exits the cranial cavity via the internal acoustic, or remember, internal auditory meatus. And so that is what we will put for the skull exit for cranial nerve 8. All right. Questions on that?
Do you want us to know that branch 1 goes to does the sound in the cochlear, and then branch 2 is, or we can
No.
just say the sound?
No, we did. You were correct in that we differentiated the 3 branches of the trigeminal, but no, you don't need to know which branch goes to which one. No, because again, you're right. There are branch 1 and branch 2, but they're also called the vestibular branch and the cochlear branch, which again associate with the names. So I think it's intuitive enough where we don't have to worry about distinguishing them. Okay, great question though. All right, anything else on 8? All right, perfect. So that brings us, again, notice we've done 6, 7, and 8, which are here up along the top of the medulla, just underneath the pons. And then remember, as we talked about, we are going to go down the lateral aspect of the medulla for the next 3, 9, 10, and 11. Many models and illustrations choose one of 2 ways to emphasize this. Notice, as we see here, they've clearly differentiated the 3 branches on this particular model or illustration here. But remember when we looked at this on the website, so let's go back here and now go to the reproductive nervous brain. And we want the cranial nerves. Perfect. Notice when we looked at this picture from the model, they have those same 3 cranial nerves here all put together. Now, again, when we look closely at this, you can see that they do have a bit of a division there and there. So we can separate it and clearly see that this one here is 9, and this one here is 10, and this part here is 11. So we can see those divisions on it. We see it here even better. There's the notch and there's the notch that separate these 3 things. So there are definitely, both model and illustration show 3 nerves. This one happens to show all their axons kind of coming together, whereas the other one makes a point of showing them separate. Now, the reason they do this is because these nerves, these axons do all come together and they all leave the skull from the same location. So the good news is the skull exit for 9 is also going to be the skull exit for 10, is also going to be the skull exit for 11. And so the fact that they have the 3 of them here together is a good reminder that they travel together. And that is why that they put them together like this. They're the 3 amigos. They like to hang out with each other. Again, often in the illustrations, they will separate them to emphasize them so you can more easily see them. But I think you can still fairly easily see them on the model as well. And notice here again on the side, they show all 3 of these as well. All right, let's talk about 9 first. Cranial nerve 9, what is its name?
Glossopharyngeal.
Glossopharyngeal, another alphabet soup term. Glosso refers to what?
The tongue.
Tongue, exactly. Glosso refers to tongue. Pharyngeal refers to?
The pharynx.
Pharynx, the throat, absolutely. And so as you can see, both from the illustration and from the name, it tells you where it goes, to the tongue and to the throat. Absolutely excellent. Sensory, motor, or both? What is its functional type?
Both.
Both, absolutely. So it's going to have both a sensory and a motor function. Let's talk about the sensory function first. When we talk about the sensory function, I want to use the term taste, but really it is about The perception of chemicals. As you can see from the illustration, this innervates the posterior third of the tongue. This also innervates the esophagus and the larynx. And it provides us with basic chemical perception. Now, again, you are not tasting whether an ice cream is chocolate or strawberry from the back of your tongue. But things like pH of something, certain basic substrates like some sweetness or things along those lines are things that can be sensed in these locations. And it's not just in the oral cavity and the throat either. So it's not just the digestive system. If you notice also right here, it innervates a structure called the carotid body. The carotid body is a large cluster of chemoreceptors in our carotid artery. And it provides us with a tremendous amount of chemical perception in our blood. As we've talked about before, is it vitally important for you to know how much calcium is in your blood, what the pH of your blood is, how much glucose you have in your blood, how much sodium you have in the blood, all of those types of things? It's vitally important that you know that. Now, are you consciously aware of it? Do you consciously know how much? I'm about a quart low on calcium. No, you're not consciously aware of it, but it is vitally important that your body know what those things are so that it can maintain appropriate conditions. And that's what these carotid bodies do. Notice they're monitoring the blood that is going to our brain. Is it important to know what's going on in our blood that's going up to our brain? Yeah, absolutely. And so these chemoreceptors allow us to monitor the condition of the blood. So it's monitoring the chemical composition of our blood, the same way that it's measuring the chemical composition of our digestive pathway as well. So again, I've got tastes and quotes, but it's really about perceiving chemicals both inside and outside the body, right? In the oral cavity, in the pharynx and esophagus, but also in our blood. But notice there's also some motor control as well. That motor control is primarily two things, more salivary glands. So it is providing secretion of saliva into the digestive into the oral cavity. And also it controls many of the muscles of our throat. These play an important role in speech. These play an important role in swallowing. All right.
What was its role with the salivary glands?
It causes the production of saliva. We have 3 salivary glands. You don't have to worry about the names for this class. When you get to 431, we'll learn them in the digestive. But if you notice, here's a big, large salivary gland located basically in front of your ear called the parotid gland. And again, you don't need to know that name, but it is our glossopharyngeal nerve that innervates that. And if you notice, if we go back to the facial nerve, there are 2 smaller salivary glands located in the lower part of your jaw, submandibular and sublingual. And again, you don't need to know those names, but notice they were innervated by the facial nerve. So both the facial nerve and the glossopharyngeal nerve help to produce saliva for your oral cavity. All right. We know the name, we know the functional type, we know the specific functions. Questions on that? So what we need now is we need a nice big opening, something large enough that 3 different cranial nerves could pass through, maybe a skull exit, and that skull exit, skull, there you go, that jugular foramen, perfect. So our jugular foramen, again, formed by the occipital bone and the temporal bone coming together, form a nice big opening that is going to be the skull exit for 9, 10, and 11. Perfect. All right, questions on that? All right, we talked about some of the special nerves we have. Remind me again what the smallest cranial nerve was?
Abducens.
Excellent. What number was that?
6.
Excellent. What was our biggest?
Trigeminal,
And what number was that?
5.
Excellent. There was one that was located on the posterior side of the brainstem. What was that one?
Trochlear,
Excellent. And what number was that?
4.
Perfect. Right. So we have a posterior one, we have the smallest one, we have the largest one, right? Our next one is the longest one. By far, and it's not even close, our longest cranial nerve is 10. What is 10?
Vagus,
Vagus, absolutely. And what does Vegas mean? To lose your shirt at gambling?
not really.
Now, what does Vegas refer to?
Longest,
Sort of. It's kind of along those lines. Las Vegas, vagabond, they all come from the root of the same word that basically means wanderer. And if you look at this illustration to the right, you can truly see how the vagus nerve wanders to pretty much all of the organs in your abdominal pelvic cavity. Really, all of your organs in your ventral body cavity. Because it goes to the heart, it goes to the lungs, it goes to the stomach, it goes to the small intestine and the large intestine. Most of the organs in your ventral body cavity are innervated by the vagus nerve. Now, anything this big and long and wandering, what is its functional type going to be?
Mixed.
Exactly. What I would like you to say for this here is this. So as you can see, it also innervates some of the muscles of the throat and neck of the pharynx and the esophagus. So again, it does play a role in speech. It plays a role in swallowing. But what for right now, because again, we're going to talk about this a lot when we get to the autonomic nervous system. So what I would like you to say for the cranial nerve, when we talk about this as a cranial nerve, that it both receives info from and sends control to most organs of the ventral body cavity. We will talk in much more detail about what it does when we get to the autonomic nervous system. But for right now, when we're doing the cranial nerves, this will be sufficient. So it receives sensory information from the heart and it controls the heart. It receives sensory information from the lungs and it controls the lungs. And as a precursor to what we'll be talking about, it provides somewhere over 90% of our parasympathetic output. Remember, we have two branches to our autonomic nervous system, sympathetic and parasympathetic. Was parasympathetic the fight and flight one? No, what's parasympathetic again?
Rest and digest.
Rest and digest. Excellent. And again, as we'll see, rest and digest really isn't the best way to describe it. We can do better than that. So we'll do that when we get there. But for, like I said, for right now, that is sufficient for writing for your definition. And of course, and this should be easy, what is its skull exit?
Jugular Foramen.
Perfect. All righty. And there it is. Excellent. All right, let's talk about 11. 11 is really interesting. What is the name of 11?
Accessory.
Accessory nerve. Although anybody find a different name for it anywhere else?
Spinal accessory.
Exactly. It is also known as the spinal accessory. So again, depending on where you find your mnemonics, you may see it as a spinal accessory, and both are acceptable names, right? Auditory is not an acceptable name for 8, but accessory and spinal accessory are acceptable names for cranial nerve 11. If you notice, there's something really interesting about 11. Notice many of the axons of 11 actually start in the spinal cord. That is why it's referred to as the spinal accessory. And notice those axons have to actually go back into the skull. And what is this nice big opening that these nerves travel back into the skull through?
Foramen magnum.
Foramen magnum. Of course, once they get in the skull, they then have to leave the skull again. And that's what we care about. So, of course, what is its skull exit?
Jugular
Jugular
foramen.
Foramen.
Yeah, the jugular foramen, exactly. So it's still the jugular foramen that is its skull exit. But what is interesting is that many of the axons that form the accessory nerves start in the spinal cord. So they actually have to go back into the skull to then be able to come out of the skull. What is its functional type?
Motor.
Motor, exactly. And as you can see from the illustration, its primary function is to stabilize and hold the head in place, right? Stabilization and movement of the head. So if you notice, it innervates muscles like the trapezius, like the sternocleidomastoid, those muscles that help to stabilize the head and hold the head in place.
A quick question. So
Yes.
You've been saying that how we determine the function of these nerves is when, or any organ is when we lose it. Is that also the process how we ended up figuring out what each nerve is doing?
Sure. For some of them, absolutely. For some of them, it was by following the innervation of them. But yes, and for many of these things are cut, and then we see what ability is lost as a result of that. Or we find someone who's had an injury in this region and then see where the deficiency is. So yes, those are often the kind of ways that we've learned this information.
Okay.
Yep. So there you go. We've got its name, we've got its skull exit, we've got its functional type, and we have its specific function. And of course, I think we already said it, but we'll say it again. What is its skull exit?
Jugular foramen.
Jugular foramen. Excellent. Questions on 11? All right, then let's do everybody's favorite cranial nerve, and that is the last cranial nerve. And our last cranial nerve is cranial nerve 12. What is the name of cranial nerve 12? There you go, hypoglossal. Excellent. Hypo means what? Below.
Low.
Glossal refers to what?
The tongue.
Tongue, exactly. So this nerve innervates the tongue from beneath. All right. Sensory, motor, or both?
Motor.
Motor, exactly. So, and if you think about it, that makes sense. We've already talked about tactile sensation of the tongue. We've already talked about taste in the tongue, both of the front and the back. So what we need to do, again, learn some quick muscles. Here again is my incredibly precise drawing of a tongue. And basically, there are two types of muscles that are found in the tongue. The first type of muscles are intrinsic muscles. Intrinsic muscles are muscles that are found entirely within the tongue. So there will be bundles of muscles that maybe go at this orientation, or another fascicle that goes at this orientation, or one that goes straight down this way, or one that goes straight down this way, right? But the point is that all the muscles, all the fascicles are located completely contained within the tongue. And what would the function of these types of muscles be?
Change the shape of the tongue.
Exactly. How many people can roll their tongue, right? Or give it the little fluted edges or those types of things to their tongue. Your intrinsic muscles are what change the shape of your tongue. However, there are also extrinsic muscles. And extrinsic muscles are muscles that start in the tongue, but connect to some structure outside of the tongue. And what do you think the most common structure that these things connect to outside the tongue might be? Most of the extrinsic muscles of the tongue connect to what structure? That is the movable base of the tongue.
The hyoid bone?
Hyoid bone. Excellent. Remember, the hyoid bone is unique in that it's the only bone that doesn't form an articulation with any other bone. But remember, we also said it is the movable base of the tongue. And we think we see the pretty picture for it right there as well. So what do the extrinsic muscles of the tongue do?
Swallowing.
They can play a role in swallowing, although intrinsic could do that as well. If intrinsic change the shape of the tongue, what do extrinsic do?
Raise it up and elevate and depress it.
Yeah, moves it in space. So can you stick your tongue up, move it out, back, forth, up, down, left, right, all around, right? That ability to move your tongue through space is the function of the extrinsic muscles. So basically we have two types of muscles, extrinsic muscles and intrinsic muscles. Intrinsic change the shape of the tongue, and extrinsic move the tongue in space. And the hypoglossal nerve innervates both. It is responsible for changing the shape of the tongue. It is responsible for moving the tongue through space. And you guys have hit it on the head. We use that for speech. We use that for eating. We use that to swallow. We use that for all those different types of functions as well. So, only one question left. How does the hypoglossal nerve get to the tongue? What is the skull exit for the hypoglossal nerve?
The hypoglossal canal.
Yeah. Now, do we actually see the hypoglossal canal on this image? Now, if you remember, the hypoglossal canal actually traveled through a hole that was superior to the occipital condyle. So it kind of passed through that space here. And I do actually have a better picture of it here. So again, here we see with that arrow of that hypoglossal canal passing under, or really above, because we're looking at the bottom. It is superior to that occipital condyle and it passes out through it that way. We can see it here with this. I think if we actually, let's go back to a picture from the inside. When we look at the inside, no. So again, it would be on this model, it basically would be right here where it would go out that way. And the same thing obviously on this side. So we can't see, this picture didn't show it either. So we don't really have a picture that directly shows the hole, but we know where that hole would be. And then here, they actually cheat and give us a little bit of bone with a hole in it there. And there you go. Just that easily, we have identified all 12 cranial nerves. We have identified their functional types. We have identified their specific functions, and we have identified their skull exits.
I have a question. What did you say the extrinsic muscles are? Not
The extrinsic muscles are what move your tongue through space. So the ability to stick your tongue out, move it to the left, move it to the right, is the function of the extrinsic muscles.
And they're still within the tongue?
Yes, they start in the tongue, and so they would start in the tongue, but then they leave the tongue to attach to some structure like the hyoid.
Thank you.
Yep. All right. Questions on that? All right, then just that easily, we have finished our cranial nerves, which, as I mentioned, especially because we are definitely behind on what we want to cover, likely will be about 25% of your lab exam. So 25% of your lab exam is likely going to be stuff like this. Me showing you a picture or a model or a illustration of the cranial nerves with a big fat arrow pointing to something like that, and asking one of 4 questions. Identify the nerve by name and number. And your answer would be?
11 accessory.
Excellent. Identify the functional type of the nerve.
Motor.
Motor. Identify the specific function of the nerve.
Stabilizes the head and holds it in place.
I would accept that. I would also accept that it innervates the trapezius and the sternocleidomastoid. So you could say what it innervates or what it does for that. I'd be fine with that. And identify its skull exit.
Jugular Foramen.
There you go. Excellent. And since we're thinking about it, could I also ask the question the other way as well? Could I instead point to, oops, hold on. Where is my, I'll just use the same arrow. Identify the specific nerve that passes through that, identify the nerve that's a skull exit. Try that again. Identify the cranial nerve that passes through this bone feature. Be specific.
Mandibular branch of the trigeminal nerve.
Perfect. Absolutely 100% correct. Perfect. So could I show you skull exits, or here, let's do an easier one. Identify the nerve that passes through this bone feature.
1, olfactory.
There you go, exactly. So there you go. And again, I'd probably say identify the nerve by name and number that passes through this bone feature. So yes, I can show you the bone features and ask you the nerve that way as well. So that'd probably be the other way that I would ask questions on these. All right, questions on that?
What we need to do when you ask for what cranial nerve, will we need name and number every time, or only if you specify?
Only if I specify. So whatever if I asked just for the number, just give me the number. If I ask for the name, but in all likelihood, I'll probably ask for name and number for most of them. But yes, answer the question. If I just wanted the number, I will just ask for the number. If I want both name and number, I'll ask for the name and number.
Okay.
All right. Excellent. Any other questions? All righty. We're done with our cranial nerves. We still need to finish off the rest of our spinal cord. But let's go ahead. This is a good transition point. Go ahead and take our first break here. Let's come back at 9:15, and at 9:15, we will pick up from there. So let's do this first. So any questions? All right, so let's go ahead and I'll stop the recording, and I'll see you guys in 15 minutes. We finished our cranial nerves, so now let's go and finish our spinal cord. We left off last time and we were talking about the relationship between the locations in the spinal cord, the function of the neurons whose cell bodies were found there, and the pathways that their axons took. And this is a nice, good reminder as we saw those unipolar sensory neurons whose cell bodies are located in the dorsal root ganglion have their axons passing up the dorsal root to enter into the spinal cord. So as we mentioned, our dorsal root is entirely sensory in its structure and function, whereas our ventral root contains both the somatic motor and autonomic motor or visceral motor axons from those multipolar neurons coming out. So that is pure motor. And then we talked about how the spinal nerve, where they come together, is a mixed nerve, basically containing both sensory and motor information. But as we also talked about, as soon as that spinal cord comes out, and this picture does a nice job of showing how that spinal nerve comes out the intervertebral foramen between the vertebrae, it branches not once, not twice, but 4 times. Forming 4 distinct branches. Here we see this nice illustration. Let me move this down there so it's a little out of the way. Our dorsal ramus, which goes to the skin and muscles of the back. Our ventral ramus, which here we see in the thoracic region, is just going to the trunk. So the anterior lateral part of the trunk, but remember this is also what goes to the arms and the legs, the limbs. And then these 2 smaller branches, collectively known as the rami communicantes. And remember, we talked about how the lateral one is white and the medial one is gray. So we have the white ramus and the gray ramus that collectively are known as the rami communicantes. And as we talked about, these play a role in our sympathetic pathways. Here we have another pretty picture that does a nice job of showing this. So again, here we see the spinal nerve branching to form the dorsal root, the ventral root, the white ramus, and the gray ramus, those 4 branches coming off of it. Now, notice this ventral ramus, as we mentioned, is the largest of the rami. And coming off here, it's a single structure. Does it stay a single structure that just goes to just one location of the body, do you think? Do you think this ventral ramus just stays a single structure, just going to one spot? So we only have 31 different spots in our body that are innervated, because after all, we only have 31 spinal nerves. No, of course not. These rami are going to, no, here, so we got more pretty pictures showing this. The white ramus, the gray ramus, dorsal, ventral. Here's our sensory coming in. Here's our motor coming out. We did that. Excellent. All right. Now, most of the spinal nerves, most of those ventral rami branch to form elaborate networks of nerves. We have a fancy name for an elaborate network of nerves, and that is a plexus. And there are 4 main plexes that are formed by our ventral ramus. You are going to be responsible for identifying the 4 plexes. You are going to need to know which ventral roots form them and the basic parts of the body that they innervate. We may also identify one or several important nerves that would form out of those plexes as well. You need to know them and their function. I'm not, for instance, on a picture like this, going to point an arrow at that and ask you what nerve that is. You're not going to need to know that that's the ulnar nerve, for instance, on a picture. But on the lecture exam, if I asked you the function of the ulnar nerve, should you be able to say what it does? Yes. So you should know the functions of these things, but don't worry about memorizing the pictures from this. I'm not going to be asking these or showing these pictures. If we had more time, I would actually make you draw the brachial plexus. It is the most elaborate and the prettiest of the plexes, but we don't have that kind of time. So just make sure you understand this information. So we'll go through it. Now notice we keep saying most, because if you look closely at our illustration, you will see that the thoracic rami basically don't branch. These are what are located in that notch in the ribs. If you remember on the ribs, we saw that they had a notch that we called the costal groove. And we said that is where the nerves and the blood vessels sit. Well, these are the nerves. Those ventral rami sit in that costal groove. So those thoracic don't branch elaborately like the rest of them, but the rest of them form these elaborate plexes. So let's take a closer look at these plexes. Starting first with the most superior one, the cervical plexus. Cervical plexus is made out of ventral ramus from C1 through C5. And as you can see, it innervates the head, the neck, and the shoulders. Again, it helps to play a role in providing sensory information from and motor control to the head, neck, and shoulders, stabilizing them in place. Notice our accessory cranial nerve is located here because it also helps to stabilize the head and keep it in place. But there's one other really interesting nerve that I want to show you here. And that one interesting nerve that I want to show you here is the Phrenic Nerve. Anybody know what the Phrenic Nerve innervates? No one? What do you think? Anybody know what the Phrenic Nerve innervates? Yeah, exactly. It innervates the diaphragm. Now, think about this. Cervical plexus, head, neck, and shoulders. Where's your diaphragm? Where's your diaphragm located?
Below your lungs.
Yeah, below your lungs, way down here, below the ribs, right? That's not neck, head, and shoulders. So why the heck is this phrenic nerve that controls your diaphragm coming off of the cervical plexus? Why? Why have this misplaced nerve?
Are the others accessory muscles for respiration?
True, and we do need to control accessory muscles that help us to breathe, absolutely, or can help us to take an exaggerated breath, but that's not what the phrenic nerve controls. The phrenic nerve just controls the diaphragm. Well, let's think about this. When you damage a portion of the spinal cord, you lose all function below that point. So for instance, if someone has an injury in the small of their back, they become a paraplegic, where they suddenly can't move anything below their waist. A little bit higher between the shoulders, and you could become a quadriplegic, where you basically can't move anything from your head down. You can't move your arms, you can't move your legs, you can't move your trunk. But can you breathe? Yeah. Notice most spinal cord injuries occur from C7 down. So if you have an injury at the C7 location of your spinal cord, you can lose complete control and sensory input from everything below your neck, but you can still breathe. The advantage of having the phrenic nerve come off of the cervical plexus is it is in a much more protected location. In fact, if you look closely, you will see that it is made up of axons coming out of ventral roots C3, C4, and C5. And that's actually the mnemonic. C3, 4, and 5 keep you alive. Because that phrenic nerve, which comes off of the superior part of the vertebral column, come off the cervical plexus, is displaced for protection. So that even if you become injured where you can't move your entire body, you can still breathe. All right. Questions on that? All right. This is the brachial plexus. Again, not quite as beautiful as the retina, but it is close. Notice it has an incredibly elaborate organization to it. It is made up of the roots of the Ventral Ramus, C4 through T1. They form 2 divisions. Those 2 divisions end up forming 3 cords. It has this big, huge, elaborate organization to it: roots, trunks, divisions, cords. And again, I've got this beautiful flow chart that does a nice job of showing this. But again, I'm not making you learn all of this. You don't have to know any of this. It's just here because it's been in the lecture for the past. And if we had more time, we'd go over it. But here's the 2 things you do need to know. You need to know that it is made up of the Ventral Ramus, C4 through T1. And not surprisingly, if it is the most elaborate plexus, it innervates the most dexterous part of our body, our arm. And we see that with the 6 major nerves that come off of it. Again, I'm not going to point at these on a lab exam and ask you to know them, but let's identify them, and we can look at the pretty pictures that go along with it. The musculocutaneous nerve innervates the primary flexors of the elbow. What are the primary flexors of the elbow? What were the 3 muscles we talked about that flex the elbow? Bicep brachia, right? What's deep to that? Brachialis. And what was the 3rd main flexor? The misplaced one, the one that was down here on the forearm. This is a cumulative class, right?
Brachioradialis.
Brachioradialis, excellent. So there you go. Those 3 muscles are all innervated by the musculocutaneous nerve. The median and the ulnar nerves are the ones that innervate the flexors of the hand and wrist that we talked about. And remember, let's take a look at this picture here for a second. Again, you don't have to memorize this picture, but this was something that we talked about before, so I want to point out to you. Notice as we talked about, there are 2 divisions, and they've colored them yellow and green. Yellow are the nerves that are on the front of the arm, and green are the ones that are on the back of the arm. Notice your radial nerve is a posterior nerve, but when it gets to the elbow for protection, that radial nerve actually comes to the front so it can be protected in your joint cavity of your elbow, and then it goes back to the back of your arm again. But look at that damn ulnar nerve. That ulnar nerve is an anterior nerve, but when it gets to the elbow, it actually goes outside the medial condyle, putting it in a very precarious location where if you bump it at just the wrong location, it makes everybody around you howl in laughter, which is why we call it the
Funny bone.
Exactly. So here you can see that ulnar nerve, for whatever reason, doesn't protect itself in the joint cavity. Even though it's an anterior nerve, it goes to the back, putting itself in that vulnerable position. And again, if you think about it, when you hit it, you get that tingling sensation down your pinky, down your ring finger, down your arm, because those are the muscles that are innervated by the ulnar nerve. As I mentioned, the radial nerve is a posterior nerve, so it is the extensors of the shoulder and the elbow. What does it do? What muscle is the primary extensor of the shoulder and the elbow? Come on, what extends your elbow, extends your arm?
Tricep.
Tricep brachia. Remember, don't forget to say tricep brachia. Tricep just means 3-headed. We need to say 3-headed in the arm region. Tricep brachia, excellent. Axillary, notice, is a much shorter. The abductors of the arm, the adductor of the arm, deltoid and the teres minor. And the last one, this one that kind of sneaks off, this one that sneaks off here, right off the trunks, is the long thoracic nerve. Remember, we talked about your scapula has to be held in place. And if the nerve gets damaged, we talked about how it'll start to float off, that winging of the scapula we talked about. This long thoracic nerve is the one that causes that. Sometimes during childbirth, as the baby is being pulled through the vaginal canal, that stretching of the brachial plexus can irritate this nerve, and they can get a winging of the scapula on that baby as a result of that. Usually the injury is temporary and it recovers from that, but in rare instances it can be permanent. So here we have those 6 nerves that are controlling all those muscles of the arms that we learned. So plenty of examples of that. All right. So like I said, I'm not going to point at a picture like this and have you know that this is the axillary or have you know that this is the median. But do you need to know what the median nerve does, what the long thoracic nerve does? Yes. So if I ask that like on a multiple choice question or something like that, you would need to know that. All righty. It's all downhill from here. Lumbar plexus, not surprisingly, is in the lumbar region, made up of ventral ramus L1 through L5. It is primarily composed of nerves that go to the abdominal wall, to the external genitalia, and the anterior medial part of the thigh. The largest nerve of the lumbar plexus is the femoral nerve. We see it nicely right here. I make a point of emphasizing this one because it comes right out the inguinal ligament and is right next to the femoral artery and the femoral vein. If someone has a major leg injury where they're losing a large amount of blood, you can put a tourniquet around it often, but if you can't put a tourniquet around the injury, what you're taught as an EMT or as a medical specialist, like in the emergency room, is to use the palm of your hand, find that inguinal ligament and put pressure right on that location. And by putting pressure right on that location, you can stop blood flowing through the femoral artery. You can reduce the blood loss and hopefully save your patient. However, it's right next to that femoral nerve. So you have to be really careful. If you put too much pressure on that location, you can actually crush the femoral nerve. Now, you would think that most people would be okay having a limp if it saved their lives, but you know as well as I do, we live in a litigious society. So as always, make sure before you save that person's life, make sure they sign the waiver. All right. The last and least elaborate, notice it's not nearly as all convoluted as the other ones are, is our sacral plexus. Sacral plexus is made up of ventral ramus from L4 to S5. And notice this is primarily a posterior plexus, supplying the buttocks, the perineum, and the posterior part of the leg and the lower extremity. While the sacral plexus is the least elaborate plexus, no, I haven't seen anybody who got sued because they crushed the femoral nerve. But I have seen someone who have had to apply that pressure to the femoral artery to maintain to decrease blood loss. So I have seen that, but I don't know if the person had a limp as a result of it. So again. But while it's the least elaborate, this also contains our largest nerve. The largest nerve in the body is the sciatic nerve. As you can see, the sciatic nerve comes out the greater sciatic notch of the ilium, and it innervates the entire posterior part of the leg all the way down to the foot. Now, from an evolutionary standpoint, being upright, being bipedal is relatively new. So the muscular structure of the back is not necessarily as strong or as efficient as it could be. So muscle irritation, muscle strain, lifting things that are too heavy along that point can irritate the muscles, and that irritation of the muscles, that inflammation of the muscles can squeeze that nerve. And when we squeeze and irritate that nerve, it causes a condition we call
Sciatica.
sciatica, absolutely, sciatica. Sciatica is an inflammation of that nerve, and as any of you who have dealt with sciatic nerve issues before knows, you can get numbness, tingling sensation, weakness, pain that go down your entire leg all the way down to your foot. Yes, it is not an enjoyable experience. Laura, to answer your question, you only need to know the nerves that I have pointed out and emphasized. So if you think about it, for the cervical, for the sacral, and for the lumbar, that's only one nerve. And then obviously for the brachial, there's a few more, but we know all those muscles, so it's pretty straightforward. But no, you just need to know the ones that I've mentioned.
Can you go back to the brachial slide? It
Yeah.
looks like on the slides that you have on here, it just doesn't show the detail from
This one?
Yes, thank you.
Yep. And again, all these pictures are from your textbook, so you have those there as well. All right.
So there's 4 of them off the brachial plexus, and those are the 4.
Six nerves off the brachial plexus: musculocutaneous, median, ulnar, radial, axillary, long thoracic. While you guys are looking at this picture, I'll answer Adina's question. So again, the sciatic nerve basically starts in the small of your back, goes down your butt, down the back of your leg, and goes all the way to the underside of your foot. So depending on where and how severe the irritation of that nerve is, you can have numbness, you can have pain, you can have weakness that can go all the way down to the foot. The fact that it can radiate down your entire leg to the foot is one of the stereotypical characteristics of sciatica, right? Because most of the nerves of the back just innervate the back, but the sciatica, being the largest spinal nerve, goes all the way down the entire length of the leg. All right, did you guys get what you needed from this?
Yes, thank you.
Excellent. All right, so notice, as we've talked about, these nerves go to very specific regions of the body. And we can actually map those specific regions of the body, and they're given the name of dermatomes. Here are the dermatomes in an adult. And as we can see, specific spinal nerves innervate specific regions of the body. Obviously, this is important from a functional standpoint, but as a clinician, this can be important too. There's basically 2 main ways that these dermatomes become important. When someone is wheeled into your emergency room after being in a car injury, one of the things you typically start doing is using your probe. You start touching them on their foot and on their leg. Can you feel this? No. Can you feel this? No. Can you feel this? No. What about this? No. What about this? Yes. What about this? No. What about this? Yes. What about this? No. What about this? Yes. And back and forth. And so you can very quickly assess, they can feel this part of the leg. They cannot feel this part of the leg. So that means that their injury must be between the L3 and the L4 region of the spinal cord. So we can very easily and quickly evaluate that. The other way this becomes significant from a clinical standpoint is there are such things as retrograde viruses. A retrograde virus is basically a virus that lives in your spinal cord. And in times of stress or other types of triggers, it can be expressed out onto the body, primarily onto the surface of the skin. Right? Shingles is a great example of this. With shingles, when it expresses itself, you get a rash. However, does that rash encompass the entire surface of your body? No, typically what'll happen is you'll get a rash that'll form like a band in just a specific region of your body. And for instance, if your rash expressed itself like this right here, then you would know that that virus was located in the T7 and T8 region of your spinal cord. So that when it expresses that rash, you get a band-like stripe just in that specific region. All right. So questions on dermatomes. All right, excellent.
Sorry.
Oh, go ahead.
The retrograde viruses, they're hiding within these nerves?
They're living within the spinal cord, basically what it is. So what happens is it's a virus that infects your body and gets into some place like your spinal cord. And so what happens is, like I said, there are different things that can be triggers. Stress is a common trigger, but certain dietary things can cause them to be expressed, or other things along those. Caffeine can sometimes be a trigger for these types of viruses, and then they will express themselves back out the nerve. That's basically why they're called retrograde, because they go back out the nerve from the spinal cord and then express themselves like by forming a rash on the surface of the body. Okay. All right. The last thing we need to talk about for our spinal cord is to talk about our reflexes. Again, one of the things we talked about is our spinal cord is part of the central nervous system. So its job is to make decisions. Its job is to process information. And again, it isn't the most elaborate decisions. It isn't the most elaborate information. It's not going to decide, what you're going to eat for breakfast, or who you're going to fall in love with, or what you should be when you grow up. But it does make important decisions. And those decisions we make, we call the spinal reflexes. Now, what is the key to a reflex? When we define a reflex, how do you define a reflex? What are some of the important characteristics of reflexes? Involuntary, excellent. Right, it isn't something we have to consciously think about. What else? How else would you describe a reflex?
Predictable.
Excellent. Oops. Predictable is a huge characteristic of this, right? One of the things, the first thing that happens when you come into the doctor's office for a checkup is he hits you in the knee with a hammer. And when he hits you in the knee with the hammer, what do?
Kick him.
Right, exactly. The leg goes up in the air. If he hits you in the knee with the hammer and your arm goes up in the air, you're getting more testing, right? So again, one of the advantages of these from a diagnostic standpoint is they're predictable. They're always supposed to do the same thing. And if they do something different, right, then it's a big deal. Excellent. And the other big, huge, important factor about a reflex is it is fast. Absolutely. Excellent. Excellent, excellent, excellent. You guys are absolutely correct. A reflex is a fast, involuntary, and predictable response to a specific stimulus. And notice that is true for all reflexes. All reflexes are fast, involuntary, and predictable. However, reflexes come in different flavors. For example, a reflex could be a spinal reflex or a cranial reflex. What do you think the difference here is?
Where the sensory information came from?
And how does that sensory information get in? How does that motor information get out? You're 100% correct, but take it the next step. How does information get in? You're overthinking it.
What do you get in from where? Like
So-
from your hand or your foot or your...
And what carries that
From
information?
cranial spinal nerves.
Nerves, exactly. The difference here are the nerves involved. Right? If, for instance, I hit you in the knee and your knee kicks out, what kind of nerves are involved in that process?
Spinal nerve.
Spinal nerves. If I shine a light in your eye and your pupil constricts as a result of that, what kind of nerves are involved in that process?
Cranial nerves.
Cranial nerves. Which cranial nerves, just out of curiosity?
2, optic.
2, that's the visual coming in, right? So you shine the light, but then the pupil constricts. Which one would be involved in that?
3, ocular motor.
There you go. So notice that shining the light in your eye and having your eye constrict involves a function of both 2 and 3. Cranial nerve 2, perceiving the light. Cranial nerve 3, controlling the pupil. Excellent. So whether it's a cranial or spinal nerve, the difference is which nerves are involved. Reflexes can be somatic or autonomic. What's the difference here?
Like your heart rate increasing would be autonomic, or your leg kicking out would be somatic.
How do you know that? You were 100% correct again. So what's
One
the
is a
difference?
skeletal muscle and one is a cardiac or smooth.
Exactly. The difference here is the effector. Be careful, it doesn't just have to be muscle type. Remember, if it's somatic, what would the effector be?
Glands as well.
Yep, exactly. So, but for somatic, if it was a somatic reflex, what would the effector be?
Skeletal.
Skeletal muscle, exactly. Whereas if it was an autonomic or visceral, it would be, as you guys have pointed out, smooth muscle, cardiac. Well, let's just do it this way because I'm running out of room. Smooth, cardiac, or glands. It could involve glands as well. Innate versus learned or acquired. What's the difference here?
Innate can be something you have and you have not. Well, you haven't learned, so something you're born with.
Perfect, right? So really the difference here is when acquired. Some reflexes we are born with. You can take a newborn baby, rip it out of the womb, and the first thing you do to it is you touch it on the cheek. And when you touch that newborn baby on the cheek, what happens?
It turns towards it.
It turns towards it to try to latch on. If, on the other hand, you put that brand new born baby into the driving seat of a car, and as it's in the driving seat of the car, you have it going 30 miles down the road, and suddenly have a kid jump out in front of the car. Is that baby going to reach its arm out to hold the person in the passenger seat back when you slam on the brakes? Is that a reflex that the baby is born with? No, right? Or if you're sitting in the passenger side trying to teach your teenage daughter how to drive, and you go for that brake, is that something that the baby is born with? No, these are acquired or learned reflexes, right? Yeah, the mom arm. The mom arm is definitely an acquired reflex. Although I'm not sure I like the name mom arm because I do it too. Does that make me a mom? But
Parent.
parent. Okay, I like that. Parent arm. Excellent. All right, so those things are along that way. So yes, flinching upon a sound or things like that, right? That startle reflex is an example of something that is innate, something that we are born with, right? On the other hand, right? Knock, knock.
Who's there?
Pavlov, just checking, right? Who was Pavlov?
He made his dog salivate with the bell.
Right, exactly. He would show a steak to the dogs and ring a bell. And when they saw the steak, smelled the steak, they would salivate. Then he'd show them a steak and ring a bell, and show them a steak and ring a bell. And eventually he'd ring a bell and they would salivate. He taught them a reflex, right? It wasn't like they consciously were like, ooh, I'm going to get food, let's salivate. But that's what he basically taught their autonomic nervous system to understand. So it was an acquired reflex. Right? I think those are pretty simple and straightforward. The next couple have more to do with the hard wiring of these things. Not quite as intuitive, but I think we can still make sense of them. A reflex can be inhibitory or excitatory. What do you think the difference here is?
Could be like slowing down the heart rate or speeding it up.
Exactly. You've got absolutely the right idea. Basically, the difference here is the effect on let's say it this way so it doesn't sound as weird. The influence on the effector. Is it inhibiting production of a gland or increasing production of a gland? Is it causing a muscle to contract or is it causing a muscle to relax? Is it increasing heart rate, decreasing heart rate? You've absolutely got the right idea. Yeah, so again, yes, that startle reflex is absolutely a reflex. All right. And again, some more wiring issues. Let's start with the easy one first. What do you think we mean when we talk about a contralateral versus an ipsilateral reflex? What does
Is it
contralateral and ipsilateral mean? Go ahead.
Contralateral is the opposite side, ipsilateral is the same side.
Excellent. So when I touch something hot and I pull my hand away from that hot thing, is that going to be an ipsilateral or a contralateral reflex?
Contralateral.
Contralateral?
Well, let's think about this. I touch something hot with my hand. That information comes into my spinal cord. My spinal cord makes a decision and sends that information out to the same hand to pull my hand away. In that case, did the information cross sides of my body?
Nope.
No, so that would actually be an ipsilateral. With an ipsilateral reflex, all the processing is on one side. But let's take it the other way. If I am walking, as I'm walking with my feet, if I step on something hot, do I just pull away my right foot from that painful thing and then suddenly I fall over as a result of that? No, if I pull my foot away, or I step on that Lego, I pull my foot away from the Lego, but notice at the same time, I have to extend my other leg so that I can maintain my balance and don't fall down. Notice in that case, information is crossing the midline. And so if information crosses the midline, that would be a contralateral. So a contralateral reflex is when information crosses the midline. So reflexes can be both ipsilateral and contralateral. I would say startle reflexes are innate. With that newborn baby, if there is a loud crash, that baby will definitely startle as a result of that and could potentially cry. So I would say that that is probably an innate reflex.
What about
Is
with
she
the
thinking like
bear with
PT
X?
sound type things?
I'm sorry, say again. The two of you talked at the same time.
You can go.
Maybe she's thinking about sounds like PTSD, like you hear a big engine backfire and it brings back a response from something you experienced. Would that be
Oh,
more
so yes,
learned?
so that kind of a startle reflex, yes, absolutely. That would be more something that would be acquired. Yes, absolutely. One of the things, remember, I think we talked about this in this class. I think it was this. This is the problem of bouncing back and forth between 430 and 431. Remember one of the things we talked about that they try to do with post-traumatic stress disorder is they try to weaken the strength of those connections. What happens is when you have a traumatic event, that process becomes kind of hardwired as a result of that. And so they will use light stimulus, they will use sound stimulus, things like that to try to weaken that connection so that when you have stimulus A, like a loud sound, you aren't instantly brought back to that stressful situation or that stressful environment. So yes, so that would be an example of a learned behavior that we then try to help them to unlearn. All right. And the second question?
I was just wondering, like, the bear coming in with X, you know, like kind of what kind of where that would kind of fall under, because I feel like that might be several different things.
Well, so that's a great question. One of the things that they found, and again, this is one of those things that is really difficult to study because you can't talk to a baby. You can't ask a baby questions. But they do a lot of these developmental studies. It's really interesting. One of the classic examples is they put these babies on a table. And the table has basically a glass portion of it that looks like an edge. So what'll happen is the baby, as it starts to crawl around, can become aware of that edge and may be hesitant to go out onto the glass part because of the appearance of the wedge. Whereas if they take a baby that isn't mobile yet, isn't able to crawl, and they put it right by the edge or near the edge, it's not stressed. It doesn't appear to be stressed by that at all. So obviously our understanding of depth perception, our understanding of things like that are things that have to be learned to some respect. I think that in the case of a bear with an axe, a baby has no way of knowing that a axe is something that is dangerous or a bear that is something that is scary inherently that way. Now, something that large and unfamiliar could be startling and upset them that way. You see that sometimes with babies tend to have a more negative response to people who have big shaggy beards. So things along those lines. So you're right, it probably falls somewhere in there. The familiarity versus unfamiliarity versus, obviously they don't know what a bear is and what a bear can do. Obviously they don't know what an axe is and what an axe can do, but something novel could be scary to them that way. So yeah, I think it kind of falls somewhere in between on those things.
Will that still be kind of where it'll be kind of an ipsilateral and also could be excitatory and autonomic? Like I
Yes,
can
so
all
I would,
fall.
so I would say that it would definitely be autonomic, because again, when you have things like an increase in heart rate, a dilation of the eyes and things along those lines, absolutely. And this is exactly what we're going to be talking about with the autonomic nervous system. That fight or flight response is definitely exactly where we're going to be going next. We're going to talk a lot about the sympathetic nervous system and the parasympathetic nervous system. And yes, you're right. It is a lot of functions, that fear response, and some of them are excitatory and some of them are inhibitory. Absolutely. But they're all mostly autonomic, affecting glands, smooth muscle, cardiac muscle. All right. The last way we can identify, and I'm going to cheat here and put a big box over this so I have a little drawing space. The last way we identify our reflexes is by the number of neurons involved. One of the most basic reflexes we can have is a reflex that involves one neuron carrying in information, communicating with one second neuron, which then influences and affects some change. Notice in this case, it only takes the simplest simplest reflex only requires 2 neurons. And if we have 2 neurons, how many synapses do we have in this communication pathway?
1.
Right, exactly, and 1 synapse. So this simplest of reflex that only has 2 neurons and 1 synapse, we would call a monosynaptic reflex. Others require more wiring. It is going to require 3 or more neurons. And if it requires 3 or more neurons, then as a result of that, you are going to have 2 or more synapses, right? We're going to have a synapse here and a synapse here. And that, in that case, would be a polysynaptic reflex. All right. So we have talked about many examples of reflexes. What we are going to focus on is we are going to focus on spinal somatic reflexes. And so we're going to look at 2 examples. There are really 4. Your book does a nice job of describing all 4 spinal somatic reflexes, but we are just going to look at 2 of them. So we'll identify 2 of them and talk about what happens with them. So let's see those 2 that we are responsible for. Now, the good news is we're talking about a reflex arc like it's something new, but it really isn't. It's really just about maintaining homeostasis. And so if you think about what we talked about from literally the second day in class, there are 5 things that you need for a reflex, right? Oops, hold on. You need some type of stimulus. You need something that perceives that stimulus, some type of receptor. And then, of course, that receptor is going to have the afferent pathway that is going to carry that information in. Oops. We have our command center, which of course in this case is going to be, well, actually, hold on. Let's do it this way. We have our stimulus. We need a receptor to perceive it, an afferent pathway to carry it into our command center, which apparently also was spelled, where we process the information, make sense of the information, and make our decision. From there, we have our efferent pathway out, which carries the information to an effector. And then we're brought back into balance. These are the 5 things that we need for a reflex. Now, as I mentioned, there are 2 somatic spinal reflexes I'm going to hold you responsible for. They are the stretch reflex and the flexor reflex. So let's take a look at those. And I'm going to go ahead and draw them just to simplify. Your book's got some nice pictures, but I'm going to draw them. So let me do that. All righty. So the first thing we need is our spinal cord. So let's start with that. Move that down there. Let me move things around. Perfect. There's my spinal cord. And of course, we need to draw our butterfly. Close enough. All righty. We know we have a dorsal root coming into it. We know we have a ventral root coming out of it. Spinal nerve. And then all the remaining things that go out of that as well. All right. Our first reflex we're going to talk about is the stretch reflex. The stretch reflex is a monosynaptic somatic and ipsilateral. Spinal reflex. One of the first things we need to know is why it's important, why we need it. This stretch reflex is important to understand where our body is in space. This is the one that allows us to maintain our balance and our equilibrium, right? We talk about how, for instance, again, if I was standing here in the classroom with you today, I would be able to stand here with my eyes closed. And as long as I haven't had too much vodka already this morning, right, then I'm going to be able to hold myself in position without too much wobbling, right? One of the things that they taught us when we were talking about the online learning is they said it is important to blow on your cup, your coffee mug, so that they think that the vodka you're drinking is really hot tea, right? So when you have this like this, right, you're able to hold this balance. And the reason you're able to hold balance is because of all sorts of minor contractions that are taking place in the muscles. Remember, we talked about maintaining muscle tone. And the way we do that is inside of a muscle. And let's take a look at a muscle here. Let's say this, for instance, is my rectus femoris. Inside of my rectus femoris, there is a specialized sensory structure known as a muscle spindle. That muscle spindle basically tells me how much the muscle is being stretched, what the length of the muscle is. So if you think about it, if I'm standing here and I slowly start to lean back, as I start to lean back, my rectus femoris is stretched out. And as my rectus femoris is stretched out, this muscle spindle starts firing action potential saying, hey, the muscle's being stretched out. I'm falling backwards. So what do I need to do? I need to contract the muscle to bring me forward again. And this is exactly what your doctor is taking advantage of. This rectus femoris, as we know, is connected to the quadricep tendon, which connects to the patella, which connects to the quadricep, the patella tendon to the tibial tuberosity. And that's what the doctor hits with the hammer. With the hammer, the doctor basically hits, whoops, I lost my picture. Oh, there we go. The doctor basically hits your quadricep tendon with a hammer. And when it hits on this hammer, what happens is it rapidly pulls on the muscle. And it tricks the muscle spindle into thinking, oh my goodness, I'm falling way back. My leg muscle is being stretched out really far, really rapidly. So what does your body do to respond to that? It rapidly contracts the muscle and your leg kicks out. So our goal is to maintain balance. Our goal is to maintain muscle tone. And it starts right here with our first structure we need. And like I said, this is our sensory receptor. So we have a sensory receptor here that is going to perceive the information of the stretch of the muscle. Now, the second thing we need is a afferent, or of course, as we also know, sensory pathway to carry this information into the spinal cord. Oops, I didn't want to change that. So let's, oh, didn't want to do that either. There we go. So one receptor. Two, afferent pathway. Now, luckily, we know some anatomy. What type of neuron is going to carry this sensory information into our spinal cord? It's not a trick question.
Unipolar?
True. Okay. Well, I was looking for sensory, but you're right. I guess I didn't specify. You're right. Functionally, it would be a sensory. Structurally, it would be unipolar, which is exactly the next question I was going to ask. And where would the cell body of that unipolar neuron be located?
Dorsal ganglia?
Excellent. So here in our dorsal root ganglion, we would have the cell body of our unipolar neuron. So basically, this sensory information would come in the nerve up the dorsal root, where again it connects to its cell body, and it carries this information into our posterior gray horn. Where it's going to synapse. Now, this is a monosynaptic reflex. It only uses one synapse. So what it actually synapses on is our somatic motor neuron. And where would our somatic motor neuron be located?
Anterior gray horn.
Exactly. So notice we need a somatic motor neuron. So let's draw one of those. What is its structural classification?
Multipolar.
Multipolar. Excellent. Where is its axon going to go? What is its axon form?
An efferent pathway,
True, but does it go out the dorsal route or does it go out the ventral route?
ventral root.
Goes out the ventral route to the spinal nerve. Excellent. So what happens here is our unipolar sensory neuron synapses on our somatic motor neuron. This right here is our command center. Command center, of course, is in the gray matter. This is where we process information and we make a decision. In this case, and this one here, this is an excitatory synapse, meaning that when our unipolar neuron fires an action potential, it excites our somatic motor neuron, and our somatic motor neuron produces action potentials. So we excite the synapse, we fire action potentials in the somatic motor neuron, which then forms our efferent pathway that goes out the ventral root to the spinal nerve. And in this case, what is our effector going to be? What do you think our effector in this reflex is? Well, if it's my rectus femoris that is being stretched out, what do I need to do?
Make it contract.
Yeah. Notice in this case, the effector is the same muscle that we had the receptor in. So in this case, it is going to synapse on that same muscle. And in this case, our effector is the exact same muscle. In this case, the rectus femoris. And of course, it excites the muscle and the muscle contracts. Right, and just because we know it, what neurotransmitter is released here at this synapse?
Acetylcholine.
Yeah, exactly. We're going to release that acetylcholine at the neuromuscular junction to stimulate this muscle to contract. And there you go. Those are our 5 components. Receptor, afferent pathway, synapses of the command center where we process information, efferent pathway, effector. A monosynaptic ipsilateral somatic spinal reflex. Now, I drew it, but should you be able to describe this in words if necessary? Yeah, absolutely. All right, questions on this one? I will save this and share this with you, but I need to erase it so we can do our second one. So questions on this? All right, let's do the second reflex you're going to be responsible for. The second reflex you are going to be responsible for is what is known as the Flexor Reflex, or what is also known as the Withdrawal Reflex. Remember, what did we say would happen if you flexed all of your muscles in your body at the same time?
Fetal position.
Yeah, you would curl up in the fetal position. So notice a flex or withdrawal is a protective reflex. This is the one when you touch something hot, you pull your hand away from it. This protects us by pulling us away from something that is harmful. Now, our flexor reflex, we will focus on the arm because it can be contralateral, but we'll focus on it in the arm. So it's an ipsilateral. But in this case, it is a polysynaptic, ipsilateral polysynaptic somatic spinal reflex. Now, obviously we need a spinal cord. So let's start by drawing that. And again, we're going to need a dorsal root with a dorsal root ganglion, a ventral root, and a spinal nerve. Now, the first thing we are going to need is a receptor. In the case of a withdrawal reflex, what is the receptor? Let's say with my hand, oops, yeah, this will work. Gotta get it. There we go. There's my pinky. I touch a tack with my thumb. What's the receptor in this case? What am I perceiving? Let's start there. What type of stimulus am I perceiving?
Pain.
Pain. Only in the integumentary system I had to learn the special sensory receptors that allow me to perceive pain.
The corpuscle?
Corpuscles, remember, laminated corpuscles give us pressure. Tactile corpuscles give us that fine discrimination. But what was it that gave us pain and tickle and itch?
The free nerve endings?
There you go. So here in our finger, we have a free nerve ending. This free nerve ending that allows us to feel and perceive that pain in our thumb when we touch that tack. We are now going to need an afferent pathway. And the good news is we kind of already figured this one out, right? What is the structural classification of the neuron that provides the afferent pathway?
Unipolar?
There you go. And where is the cell body of that unipolar neuron located?
Dorsal root ganglia.
Perfect. So we are going to have a sensory neuron that carries this information in to our posterior gray horn through the dorsal root, connected to that cell body. So we have our unipolar neuron located in the dorsal root ganglion, carrying that information in. Now here's where things get a little bit trickier. Let's jump ahead. What are our effectors that we are going to want to use in this process? And notice my use of the plural here. What are the effectors? If I touch something sharp with my thumb, what effectors do I want to do? What do I want to do as a result of this?
Bicep brachia.
Excellent. So one of the effectors is going to be an arm flexor, like the bicep brachia. Are we going to want another effector? The extensor. Excellent. Why do I want both? Do I want to stimulate both? Do I want to contract both?
Contract both to pull away, protect.
Now, if I contracted both, would that actually pull me away?
Does it have you inhibit one and use the other?
Exactly. Think about it. If you grab onto an electrical wire, electricity runs up your arm, your entire arm. That not only can it be very dangerous because it can cause damage and burning and all of that, but it also stimulates all of your muscles, so all of your muscles contract. And when all of your muscles contract at the same time, what happens to your arm? Contract all the muscles in your arm at the same time. Where does it go?
It goes nowhere.
It goes nowhere. It locks into place. So you guys absolutely have the right idea. We want to excite or contract our flexor so that we can pull away from that painful thing. But to make sure we pull away, we need to inhibit or relax our extensors. So in this case, we are actually going to have two different effectors. And I'll put them down here. They should be in the arm, but we'll put them down here. This one is our flexor, like the bicep brachia, as you guys mentioned. And this one would be our extensor, like the tricep brachia. So if we have two different effectors, we need two different motor neurons to control them. So when we look at our efferent pathways, actually, let's do it this way. We need two somatic motor neurons. Now, where are these somatic motor neurons going to be located?
Anterior gray horn.
Excellent. So they're going to both be located in the anterior gray horn. So there's one. And there's two. What is the structural classification of these neurons?
Multipolar.
Multipolar. And what structure do their axons form as they leave the spinal cord?
Ventral root.
Ventral root into the spinal nerve. So this one goes this way. Excellent. So 2 somatic neurons to each muscle. And we are going to want different effects. Now, clearly, we can't get these 2 neurons to do 2 different things with just one synapse. So it's not surprising that this is polysynaptic. But now what we're left with, and I'll do this all in green. Let's look at the, oops, no, hold on. Oh well. That's all right, that's fine. So that was part 5. This was part 4. So again, let's look at part 3. Part 3 is our integration. Oops. Right, this is our command center. Or again, this is where we make decisions. And we make those decisions with synapses. So the first thing that happens is that our sensory neuron directly connects to the flexor motor neuron and excites it. So this comes here, this comes here, it excites this. And of course, if it excites it, then as a result of this, this fires an action potential. And that action potential causes a contraction of our flexor. That's pretty simple and straightforward. Yay? But the other thing that our sensory neuron does sensory neuron also directly connects to an interneuron. And excites it. So it synapses on an interneuron. And what would the structural classification of an interneuron be?
Multipolar.
Multipolar, excellent. And again, it excites it. But what this interneuron does inhibits the extensor motor neuron. So this interneuron inhibits our extensor motor neuron. And if it inhibits it, no APs are fired. If no APs are fired, there's no muscle action potential. And if there's no muscle action potential, the muscle relaxes. So notice this reflex both contracts the flexor and relaxes the extensor so that I can pull my arm away from that painful stimulus. Notice we couldn't just do that with 2 neurons. So we needed 4 neurons to do this with 3 different synapses. to do this slightly more complicated reflex. But this assures that we pull away from that painful stimulus. Questions on that?
So the interneuron is what inhibits the
Effectors, the extensors, motor neuron, yes.
okay, thank you.
Yeah. So notice, thanks to this interneuron, when our sensory neuron fires an action potential, so think about it, this one has an action potential. That causes this one to fire an action potential, which causes an action potential here and causes the flexor to contract. It also produces an action potential here on the interneuron. The difference is the interneuron inhibits the extensor. So when it is inhibiting the extensor, remember inhibiting means that no AP. And with no action potential, there's no neural action potential going to a muscle. With no neural action potential going to a muscle, we get no muscle action potential, and that muscle relaxes.
Is it inhibiting just based on the neurotransmitter it's releasing?
Exactly. It's releasing a different neurotransmitter. Yep. So one motor neuron's being excited, one motor neuron's being inhibited. So one muscle fires, one muscle doesn't.
I have a question, Professor.
Yes.
Do you have the picture saved for the stretch reflex?
Yes. So
Because when we go back to the recording, the slide, basically the left side or the right side gets covered because it has all of our tabs open, and it just doesn't show the right side of the screen all that well because you and the rest of the people, whoever is logged in, that tab is sitting there, so I can't really get the right side.
You can close that.
Not right now in the recording for YouTube.
Oh, the YouTube recording.
well, I have it down at the bottom now, so it shouldn't be blocking any of the images. And both of these pictures I've saved these pictures, and so they'll be posted on the Canvas site. So most of these pictures, most of these drawings like this that I do, they're posted there.
Thank you.
Yep. All righty. Any other questions on these two reflexes? All right, excellent. With that, we are done with the spinal cord, and we can now finally go into the last major topic we're going to talk about, and that is the autonomic nervous system. So I think I've saved this already twice, but I'll save this a third time just to make sure. So with that, we are done with our spinal cord, and our next goal is to talk about the autonomic nervous system. So this is what we'll do next, but again, this is a nice natural stopping point. So let's go ahead and take our next break here. It is 10:35 right now, so that means let's come back at 10:50. And I will start the recording at that part. And we can finally get on to our autonomic nervous system. All right, questions on any of that? All right, see you guys in 15 minutes then. Let's go ahead and get started. So the last major bit of business we have to cover today and on Tuesday involves the autonomic nervous system. Now, our autonomic nervous system regulates the activity of what effectors again? What are the effectors that are controlled by the autonomic nervous system?
Sympathetic and parasympathetic.
Those are the two branches, but what are the effectors that the sympathetic and parasympathetic control?
Cardiac muscle, smooth muscle, and
Someone help her out. Cardiac muscle, smooth muscle, and Bueller.
Glands.
There we go. Excellent. Smooth muscle, cardiac muscle, and glands. Absolutely. Again, autonomic nervous system gives us that involuntary control. We don't have to tell our stomach to start churning up that cheeseburger we had for breakfast. We don't have to tell our heart muscle to beat faster when we see that bear with an axe or any of those types of things as well. Its function, obviously, is to maintain homeostasis. And it does this through autonomic reflex arcs. Luckily, we know what a reflex arcs involves, so we can work those out pretty easily. Now, if we think about our autonomic nervous system, while we have autonomic sensory, when we talk about the autonomic nervous system, it is a motor pathway. And again, as we talked about, if you think about it, this makes sense. It controls smooth muscle, cardiac muscle, and glands. Let's take that stomach as a perfect example, right? Certainly, when you have that cheeseburger for breakfast, your stomach stretches as a response to that. But that stretch triggers a reflex that causes it to start to contract on that food more readily. But can other pathways influence the function of our sensory pathways influence the function of our stomach?
Mhm.
Yeah, if you smell someone cooking that tri-tip, if you see like a Carl's Jr. commercial, nothing looks better than a hamburger on a Carl's Jr. commercial. They're the most amazing looking things ever, right? They never look that way in person, but on TV, they'd make a vegetarian drool, right? Just thinking about, right, what the food that you had for Thanksgiving, I'm sure you could start salivating as a result of that. Absolutely. So all of our sensory information have the potential, whether it's interoreceptors, special receptors, or things like temperature, pain, right? Things along those lines. Can those affect and influence your things like your heart rate or things like production of saliva and things along those lines? Absolutely. So all of our sensory input has the ability to affect that motor pathway. So when we talk about the autonomic nervous system, it is really just a motor pathway. Now, again, it's involuntary, so it's not taking place up here in the cerebrum where we're doing our conscious thought. Instead, most of the gray matter, most of the cell bodies involved in these reflexes are found in nuclei inside the medulla and inside our hypothalamus. Right? These are areas where, again, we don't have conscious, voluntary control of. And like I said, it's a motor pathway. And the good news is we've already learned a lot about a motor pathway. We learned about the somatic motor pathway. And so we can use that understanding as a basis for seeing what the autonomic pathway would look like. They are going to be similar, but obviously not identical. They're going to be different in their effectors, right? For our somatic, what is the effector?
Skeletal muscle.
Skeletal muscle, excellent. And for our autonomic, what are the effectors?
Cardiac muscle, smooth muscle, and glands.
Excellent. So we have those. Another difference is going to be in their anatomical pathways as well. And then lastly, the neurotransmitters they use and the effects of them. Let's take a look at this. Our somatic motor pathway starts in the spinal cord, and where in the spinal cord does it begin?
Anterior gray horn.
Excellent. This starts in the anterior gray horn. With a somatic motor neuron whose axon comes out the ventral root to the spinal nerve. It is going to get to an effector. What's the effector in the somatic motor pathway again?
Skeletal muscle.
Excellent. So we can draw that as a nice big cylinder-shaped cell where it's going to form its synapse. All right. And when it forms that synapse, what neurotransmitter is released?
Acetylcholine.
Excellent. What is the effect of that acetylcholine? Is it excitatory or inhibitory?
Excitatory.
Excellent. Stimulating it to go. And so notice, from central nervous system to effector, we just have one neuron. It releases acetylcholine, and is it excitatory? And really, if there's any new piece of information we can add to this, none of this is new. And this last piece really shouldn't be surprising, but the axon on this, based on what you know, do you think it's going to be myelinated or unmyelinated?
Myelinated.
Yeah, exactly. So indeed, it is going to be myelinated. So let's cheat and draw some myelin on there. Bingo. Our somatic motor pathway. We know that, we've got that down. Let's see how this compares to our autonomic motor pathway. It also is going to start in our central nervous system. In the central nervous system. However, where does it start in the spinal cord?
Lateral gray horn.
Excellent. This one starts in the lateral gray horn. Now, it's still a motor pathway. So what is the structural classification of the neuron? Still multipolar. Its axon still is going to come out the ventral root. And our goal of it is still to get to our effectors. And what are the effectors in our autonomic motor pathway?
Smooth and cardiac muscle, as well as glands.
Excellent. So just for the heck of it, we'll draw a heart and we'll draw a spindle shape, smooth muscle cell, and some globby gland looking thing. Excellent. So our goal is to get here. However, in this case, from central nervous system to effector, in our autonomic pathway, it actually takes two neurons. So this first neuron starts in the central nervous system, but it doesn't go all the way to the effector. Instead, what happens is it synapses in a structure where there are a large number of motor neurons, cell bodies. What would we call a structure that had a large collection of cell bodies outside of the central nervous system?
Ventral root?
Nope. So ventral roots, remember, are made of axons. These are cell bodies. What do we call a cluster of cell bodies outside?
Ganglion.
Ganglion.
Ganglion, exactly. So what we have here is an autonomic ganglion. So our first neuron starts in the central nervous system and synapses on an autonomic ganglion. This first neuron that starts in the central nervous system and synapses on the autonomic ganglion, we call, because it's before it, the pre-ganglionic neuron. And we know three things about it. One thing we know about it is that it synapses on our autonomic ganglion. The second thing we know is that it releases acetylcholine, and that acetylcholine is excitatory. And the third thing we know about it is its axon is myelinated. So this first neuron is a preganglionic neuron. It starts in the central nervous system, synapses on our autonomic ganglion. Its axon is myelinated, and it releases acetylcholine, and that acetylcholine is excitatory. Always excitatory. Now, it is going to synapse on a second neuron. This is still an autonomic neuron, so it is still multipolar. But if the first one is called the preganglionic neuron, guess what we call the second one?
Postganglionic
Post.
neuron.
The postganglionic neuron goes from the ganglion to the effector. Its axon is unmyelinated. And once again, there is a third thing we know about them. The third thing we know about postganglionic neurons is that most release acetylcholine. Of course, what is the key word to that? Most. That means not all. And indeed, there are some that release a different neurotransmitter. And that different neurotransmitter is norepinephrine. Norepinephrine has another name. Now, good news is when you're writing that out on an essay question, of course, we can abbreviate acetylcholine after you've written it out once, ACH. Norepinephrine, you can abbreviate NE after you've written it out once. Does anybody know what the other name of norepinephrine is? Excellent. Adina's got it. Noradrenaline. Epinephrine and norepinephrine are two different chemicals, but in our body, they basically do the exact same thing. So for all of our purposes, they have the exact same function in our body. But epinephrine and norepinephrine have two other names, probably ones you're more familiar with: adrenaline and noradrenaline. So norepinephrine, noradrenaline, either of those are acceptable terms for them. Now, when we're releasing one of two, and again, it's not like one neuron on Monday releases acetylcholine and on Tuesday it releases norepinephrine. But maybe one neuron going to the heart releases acetylcholine. One going to a gland may release norepinephrine. So different ones release different neurotransmitters. And are those neurotransmitters all going to have the exact same effect on all of the effectors? No. So some will be inhibitory and some will be excitatory. Let's take some examples. For instance, as we learned earlier, if you release acetylcholine onto the heart, what kind of effect do you think it has? Is it excitatory or inhibitory?
Inhibitory.
Inhibitory, we learned that. But what if instead you release noradrenaline or norepinephrine?
Excitatory.
That's going to be excitatory. So notice different neurotransmitters can have different effects on different effectors. So Haley, remember, great question. So it isn't so much that one will overpower another, but remember what we talked about, and the heart is a great example. The heart has a large amount of inputs coming into it. Some of them are going to be excitatory and some of them are going to be inhibitory. Remember, we talked about a single neuron can have as many as 10,000 different effectors coming into it, 10,000 different synapses. Some of them are going to be excitatory and some of them are going to be inhibitory. And remember, excitatory and inhibitory cancel each other out. But if we put a salt shaker's worth of norepinephrine on a heart and we dump a bucket of acetylcholine, the heart's going to slow down. If, on the other hand, we dump a bucket of norepinephrine and a salt shaker's worth of acetylcholine, that heart's going to speed up. So it isn't so much that one overpowers the other, it's just one is going to be bigger than the other. The two signals are not going to be equal. Now, is it possible that the two signals could be equal? Yes. Think about what that would be like. 10,000 inputs to the heart, 5,000 of them are excitatory, 5,000 are inhibitory. That is a massive amount of energy and resources using to send a signal to the heart. And would the heart change its activity at all with that input? No, the two would totally cancel each other out. So yeah, it would be a complete and crazy waste of energy, but technically it could happen. So there you go. Here we see the differences between the somatic and the autonomic pathways. And I think we've done a decent job of looking at this here, but we also have the pretty pictures from the textbook that show this as well. So again, somatic, very straightforward. Effectors are skeletal muscle, gives us that voluntary control. It always releases acetylcholine. It's always excitatory. And notice it's one neuron, a somatic motor neuron, myelinated from the central nervous system, from the anterior gray horn to our skeletal muscle, where it always releases acetylcholine and it's always excitatory. And really, probably the only thing here we didn't talk about before is, again, to show that the somatic motor neurons are myelinated. But really, there's absolutely nothing new in this pathway. We've talked about this pathway already. We know that one. The one that's a little bit more complicated, a little bit more different, is our autonomic. Again, it goes to our cardiac muscle, our smooth muscle, our glands. Some will release acetylcholine, some will release norepinephrine. And norepinephrine and epinephrine can be released into our blood, right, in our sympathetic nervous system, giving us that prolonged stress response. All right. And again, different neurotransmitters, different effectors, different effects. And in our autonomic pathway, we have two neurons. Our preganglionic neuron, and again, we know three things about our preganglionic neuron. It starts in the central nervous system in the lateral gray horn. It goes from the central nervous system and synapses on our ganglion. Thing two we know about it is that its axon is myelinated. And thing three that we know about it is that it always releases acetylcholine and it is always excitatory. We then have our post-ganglionic neurons, and we know three things about it. It starts in the autonomic ganglion and goes to the effector. Its axon is unmyelinated, and some release acetylcholine and some release norepinephrine. And because they can release different neurotransmitters on different effectors, some will be excitatory and some will be inhibitory. Your book has one other nice picture that does a good job of showing this. And this picture hints at one other important piece of information. Notice that other important piece of information that we see here. Hold on, I need to sneak this up to the side a little bit. Here is again our single neuron somatic motor pathway releasing acetylcholine to skeletal muscle. Here are autonomic pathways with myelinated preganglionic axons, unmyelinated postganglionic axons. Preganglionic neurons go from central nervous system to ganglion. Postganglionic neurons go from ganglion to effector. Smooth muscle, cardiac muscle, glands. Some release acetylcholine, some release norepinephrine, some are excitatory, some are inhibitory. But notice there are also going to be some anatomical differences between our sympathetic and our parasympathetic. So that's the next thing we have to look at. We have to look at the differences. While both sympathetic and parasympathetic use two neurons, use ganglions, have a lot of similarities, there are also some differences there that we have to identify as well. All right. Questions on that? All right. As we know, our autonomic nervous system has our two divisions, sympathetic and parasympathetic. Sympathetic, remember, is the one we said was our fight and flight. And as I mentioned, that is a pretty decent definition for it. Our sympathetic nervous system helps us to mobilize resources to deal with stress. Parasympathetic, we used rest and digest, but that's not really as good of a mnemonic to remember what it does. I'll give you some slightly better ones a little bit later. But our parasympathetic is really about housekeeping and maintenance of the body. So one allows us basically to use energy, one allows us basically to store energy. Now, many organs, and the heart is the great example of this, have dual innervation. What do you think I mean by dual innervation?
It can use either sympathetic or parasympathetic.
I like that. It can use, or it gets input from both the sympathetic and the parasympathetic. So there is sympathetic input into the heart, and there's parasympathetic into the heart. I like that idea of the checks and balances, Adina. I think that's a great example, right? What this allows us is very precise control. Oops. Of our heart rate. Again, this isn't a complex thought to have. Think of it in terms of your house. If your house just had a heater, you'd be okay these days. Because it gets really cold at night, the heater would come on, it would bring your temperature back up. And then it gets cold outside and your heater brings the temperature up. And it gets cold outside and your heater brings the temperature up. But if all you had was a heater, how much would you enjoy July? Not so much. the advantage of having these two, and here's really the key. These two antagonistic inputs is that it gives us that precise control. I think I used the example when we were talking about homeostasis. When my sister was pregnant with her first child, she wanted the temperature in her house to be 71 degrees. If it was even 72, 1 degree above 71, she was sweating like a pig. If it was 1 degree below 71, like 70, she was shivering. So she set incredibly precise controls to her house, and she had one of those smart thermostats, so she could do that to keep her house at a perfect 71 degrees. And with those two antagonistic inputs, you can do that, right? What type of input, what type of effect does the sympathetic have on the heart? Is it excitatory or inhibitory?
Excitatory.
Yeah, it excites the heart. What kind of input is the parasympathetic? Inhibitory, excellent. Does that mean that sympathetic is always excitatory and parasympathetic is always inhibitory? No, what if instead the effector was the stomach? The stomach gets dual innervation from the parasympathetic and the sympathetic. And what kind of input does the parasympathetic give to the stomach?
Excitatory.
Excitatory. And what kind of input does the sympathetic give to the stomach?
Inhibitory.
Inhibitory. So it's not that one is always excitatory and one is always inhibitory. They are always the opposite. So if one excites, the other inhibits. If the other excites, then the other inhibits. They're always going to be opposite. They're always antagonistic. And the advantage of this is that this gives us precise control. And for most organs that are affected by the autonomic nervous system, that precise control is vital. However, what's the pesky word in all of this that we keep talking about?
Most.
Most, not all. There are a few exceptions. So most get input from both, but not all. And I also want to go back, I don't remember who was mentioning it before about them canceling each other out or overpowering. But the other point I want to emphasize is there's almost always, for the things that have dual innervation, there is always input from both sympathetic and parasympathetic. But is it always the same? No. Sometimes parasympathetic will be more, sometimes parasympathetic will be more. So they're going to vary in how much, but there's always input to it. And because there's always input into it, we call that the autonomic tone. They're always receiving sympathetic and parasympathetic input, but sometimes it's a lot and sometimes it's a little, so that they can cancel each other out. And sometimes one will have a greater effect and other times the other will have a greater effect. But again, most is not all. There are some exceptions. Those that are exceptions are primarily innervated by the sympathetic nervous system. The good news is most of these are obvious, like the adrenal gland. Do you necessarily want a random amount of adrenaline in your body at all times? No. You only want adrenaline present in your body when you're dealing with that fight or flight response. Here it is, late at night, 3 o'clock in the morning, and because we're nearing the end of this class at 3 o'clock in the morning, you should be up, sitting at the kitchen counter, right, studying for this class, while everybody else in the house is asleep, right? And then suddenly, bang, there's a large noise outside the house. Right? You instant thought is to panic. Oh my goodness, the coronavirus is getting its way into my house. But then you realize it's just the neighbor's car backfiring and everything is going to be okay. Now, even though everything's going to be okay, does your heart rate instantly go back to normal? No, because your body has released that adrenaline into the blood and you get that more of a sustained stress response because of that adrenaline. We only need adrenaline released when we are having a sympathetic response. So it's not surprising that our sympathetic nervous system only innervates the adrenal gland. That makes sense. Most of the structures of our skin only receive innervation from our sympathetic nervous system. When do we need to produce sweat? When we're physically active, using our sympathetic nervous system, using energy. When does our hair stand up on end? When we're cold, when we're scared, right? We either contract the muscles, we need to stimulate our activity, or we need to scare somebody away by how big and scary we are by making our hair stand up on ends. And most of our blood vessels are controlled by the sympathetic nervous system, right? Think about what happens when you are stressed. When you are stressed, again, one of the ways you can tell someone's stressed or someone's scared is that their face gets really pale. Their face gets pale because the blood vessels that are skin, remember, our skin is a blood reservoir. But when we have to deal with that bear with an axe, when we have to deal with a stressful situation, what ends up happening is that we want to divert that blood to our heart, to our lungs, to our muscles to deal with that stress. And so typically our skin gets pale as a result of that. What's going on? Is it your kids? Oh, you've got young kids though,
Yeah.
don't you?
Yeah, 7, 4, and 11 months.
Yeah, see, I have teenagers. Teenagers are easy to ignore. You've got the younger ones. It's harder to ignore those. Awesome. So all of that makes sense. It's about mobilizing and getting the body ready. However, there's that pesky word most again. Most blood vessels, but not all. There are a few blood vessels associated with and receive innervation from the parasympathetic. And the parasympathetic innervates blood vessels to the erectile tissue. Where do you find that? Where do you find your erectile tissue? It's anatomy and physiology class. You're allowed to name these things. There you go. There you go. The penis, the clitoris, and the labia majora of the female, right? Arousal is a parasympathetic reflex. And again, you haven't thought of it in those terms, but I know you're aware of it because you're like me. When you take that special boy out for that big third date, right? That big third date is important. You're taking him to a really nice restaurant, buying him some really expensive food, and you expect something in return. And he knows that. So he could be a little bit nervous. And if he's too nervous and too stressed and has too much of a sympathetic nervous system, you could have difficulty getting what you need out of him, right? So that's why you do what I do. Ply him with a little bit of alcohol. He'll be much more relaxed and you can get what you need from him, right? So that arousal is a parasympathetic. Orgasm is a sympathetic reflex, right? You give him too much alcohol and he has that whiskey issue and that could be a problem. So we don't want to deal with that, right? So a good mnemonic, and we'll talk about this when we get to the reproductive system in 431, is point and shoot. Point, the arousal, is a parasympathetic reflex, and shoot, the orgasm or ejaculation for the male, is a sympathetic reflex. So most, but not all blood vessels are controlled by the sympathetic. So again, I think all of these things are intuitive. All of these things make sense. Here's the weird one. What do the kidneys do? Filter the blood. Excellent. And how important is that process? Vitally important. Absolutely. Right? While you're sitting here calmly at rest in class, about 25% of your blood is being directed to your kidneys every minute, filtering all of the waste material out of there. It's vitally, vitally important. How long could you survive with one kidney?
Forever.
Forever. Think about how crazy that is. You have a complete redundancy in kidneys. Could you survive with only one lung?
Yeah, but you wouldn't
Yeah,
have
but
good
would
tidal
you really
volume.
be able, would you be able to really live a completely symptom-free life? Could you be a professional athlete with one lung, right? Or a professional athlete with one eye, one arm? No, but you could be a professional athlete with one kidney. One kidney is completely capable of doing everything that is necessary to keep filtering your blood. Now, you probably wouldn't want to be a professional athlete if you had only one kidney, because what happens if you damage that second kidney? How long can you survive then?
Dialysis for life.
Well, but again, are you really dialysizing for 40 years? Is dialysis a long-term solution for no kidneys?
No,
No.
it loses its effectiveness over time.
Yeah, it can be a short-term stopgap, but really your only hope for survival is to get a kidney from somebody else, right? So that processing of the kidney is vitally, vitally important. So when we think of dealing with stress and housekeeping, kidney sounds like housekeeping. Kidney sounds like something that should be controlled by the parasympathetic nervous system. But it turns out filtering the blood is so important. Does our parasympathetic nervous system need to tell our kidneys what to do? No. And remember, as we said, at rest, 25% of your blood is going to your kidneys, meaning that our kidneys have a huge blood supply. And that also means a huge blood pressure. And it uses that blood pressure to do work. But what happens when I give you 15 minutes and you have to run across the street to Starbucks to get a coffee and then run back? Or you have to walk down your 3 flights of stairs to get to the basement to where the coffee maker is, right? And then back up. When you get up and walk around, exactly, when you're active, remember, as we talked about, blood goes to other areas. And so less blood goes to the kidneys. So every time you walk around, do you want your kidney function to decrease? No. So when active, our sympathetic nervous system is able to maintain high pressure in the kidney, even with less blood. So our kidneys are only innervated by the sympathetic because we need to compensate for the decrease in blood supply when we're being active. So while on the surface, kidneys you wouldn't think that kidneys would just need sympathetic input. But when we kind of understand why we need it, it makes a little bit more sense. All right. Questions on that? All righty. Let's talk first about the physiology, because I think the physiology is the part that we all understand and feel more comfortable with. So let's get this one done and out of the way. Tell me some of the effects you have from the sympathetic nervous system, your fight or flight response. When you're stressed, when that bear walks in with an axe, walks in the room, how does your body respond to it? What are some of the physiological effects? Excellent. Increased heart rate. And not only does the heart rate go up, but it also, the heart beats stronger. Right? While you're sitting here in class, these are all perfect. Wait, we'll come to these. Hold on a second. While we're sitting here in class, can you feel your heart beating in your chest? Right? Unless you had a quad shot from Dutch Brothers before class today, probably not. Right? Yeah, an exam, when you're stressed, then you feel that pounding, absolutely. So not only does it beat harder, but it beats stronger. Excellent, right? What did I see? Increased respiration. And not only increased respiration, but it dilates the airways. Right? These two right here is why everywhere I go with my younger daughter, as I've mentioned several times, my younger daughter has an extreme peanut and tree nut allergy. So everywhere we go, I carry an EpiPen, right? Because if she was to accidentally come in contact with a nut, she could undergo anaphylaxis, right? Basically, two main things happen. The one thing happens is she gets an inappropriate dilation of all of her blood vessels, and her blood pressure plummets. The second thing that happens is the mucous membrane of her airways thickens, and she has a hard time breathing. So now you can't get oxygen into your lungs, you can't get blood to your brain, and you can die as a result. So what do? Jab her, not in the heart, but you jab her in the leg with an EpiPen. Increases the heart rate, increases the strength of the contraction. And obviously, if you do that, this is going to increase blood pressure to bring the blood pressure back up, dilates the airways to hopefully get the air into her lungs, so see she can survive until we get her to a hospital. Excellent. What else does it do? What was else? Oh, hair stands up on end. So again, stimulates the erector pili muscles. Stand up. Now let's talk about the blood vessels. Do all blood vessels dilate? Yeah, I'll answer that question in just a minute. Do all our blood vessels dilate?
Not all of them.
No. They dilate to what areas?
Areas that need it the most.
True, like what?
The heart, skeletal muscles.
Excellent. Where else? Lungs. There are two other places that the blood vessels dilate to. Anybody know the other two places? Brain is a great thought, and we would love to think that, but remember, this is our fight or flight response, and this is a good learning lesson for all of you. When that bear with an axe walks into the room, do I necessarily need to be doing complicated calculus equations at that point?
Not necessarily.
No, I have two choices, right? I can fight that bear with an axe, or I can outrun my daughter. Right? Those are basically the two choices I have. It doesn't require a lot of complicated thought. So surprisingly, or not surprisingly, if you really think about it, we don't get an increased blood flow to the brain when we're stressed. We don't make the best decisions when we're stressed. So that whole, I do my best work under pressure, I'm going to wait to the last minute to write that exam or write that paper or to prepare for that exam because I do great under pressure, is complete BS. All right? So no, not the lungs, but there we go to the liver. Well, my daughter's the slowest. So my wife's, like I said, my wife's a distance runner. I'm not going to outrun her. So it's got to be one of my daughters, right? But I did choose the choice of fighting too. I mean, it depends on, which daughter it is. All right, excellent. So liver and also our adipose. Why might we want blood going to our liver and our adipose tissue?
That's where our stored energy is.
Exactly. Remember, it's about getting our resources readily available. Think of this from an evolutionary standpoint, right? 50, 100, 150 years ago, bears with axes roamed the countryside. From an evolutionary standpoint, when we had a stress response, those stresses were life and death. You really did have to decide whether to fight that bear with an axe or to run for your life. There are very few bear with axes these days. Instead, the things that stress us are that paper, that 10-page paper we have due on Friday, that work presentation we have to give on Monday, that anatomy and physiology exam due in a week. Those are the things that stress us out. And how do we deal with those things now? You sit at a computer and you type, or you stare at a textbook for hours. We still have the same evolutionary response to stress, mobilizing our resources, getting ready to do something physical. And the problem is we don't do anything physical with it anymore. I was glorious before I had kids, right? But kids are incredibly stressful. So I've lost my hair. I've mobilized all these resources that I changed a diaper with and didn't use any energy. So when you've mobilized all those resources and you don't use them, what happens to them? Yeah, they get stored as fat, exactly, right? Children are truly the worst thing that could happen to an individual, right, as a person. It is just absolutely horrible. That stresses, the things that stress us now are not the things that did from an evolutionary standpoint, but we still have these same evolutionary responses. Yes, definitely apologize to your parents. Excellent. So those blood vessels we dilate to go to all of those areas. But you guys have also pointed out we are going to constrict blood vessels to non-essential areas. Things like digestive system, things like, the other parts of our body that aren't going to be involved. And again, you don't think of it in these terms, but we're aware of it because like we talked about, your skin gets pale. Skin's another good one. Let's put skin there. Your hands get cold when you're stressed, right? Clammy. Hand gets clammy, right? Because your sweat glands become active. So that's something that happens. Our sweat glands become active. But they become cold because the blood is drawn away from there. So we constrict blood vessels to non-essential areas. We dilate it to the essential areas. All right, excellent. Sweat glands become active. What else happens? What else happens when you're stressed? I can think of at least one more good one.
Maybe like
Pupil.
shake, tremors.
Okay,
Like
so we
scared?
could get activation of muscle as in anticipation of movement. Sure, absolutely.
Pupil
What else?
dilation.
I'm sorry, Christopher, I keep talking over you.
Pupil dilation.
That's the one I was looking for. Bears with axes are very, very tricky. When we're dealing with a stressful situation, we typically dilate our pupils so we can take in more light, perceive more of our environment so that we can find those sneaky bears with axes. Right? And notice also, all of these things happen at the same time. One of the key things to this sympathetic response is that it is a big global response. It's not like my heart starts beating faster and then 5 minutes later my pupil dilates and 3 minutes after that my airways open up and 2 minutes after that my sweat glands decrease or my salivary glands get dry, right? This is all happening at the same time. A stress response is a big global response to help us to deal with stress. I think that's a really good list. Let's see what I've got written down. Pupils dilate, heart rate, force of the contraction, blood pressure increases, airways dilate, constrict blood vessels to non-essential, dilate blood vessels to essential. And we already we did talk about that too. Releasing the fuel from the liver, from the adipose, again, mobilizing those resources and decreasing digestive activity. All right, this is why you're not supposed to swim till 30 minutes after you've eaten. You have a nice big Thanksgiving dinner, you shouldn't jump right in the pool and start swimming laps. As you decrease blood flow and decrease digestive activity, you don't completely and fully break down those foods, especially fats, lipids. And so what happens is those undigested foods can cause cramping and other type of intestinal discomfort as a result of that. And if you're half a mile out to sea, cramping can be a very bad thing. All right. I don't think there are too many surprises here. I think these are definitely the types of things that we think about. And certainly we came up with pretty much everything on this list. So like I said, I think the physiology of our autonomic nervous system is pretty obvious. And here's the good thing. The sympathetic and the parasympathetic are antagonistic. So one of the things you could think of is anything the sympathetic does, pretty much the parasympathetic does the opposite. So sympathetic increases heart rate, parasympathetic brings it down. But as promised, there are some mnemonics better than rest and digest. One of the good mnemonics for the parasympathetic is SLUD. SLUD helps us to remember the 5 main physiological processes that are controlled by the parasympathetic nervous system. Salivation, which is of course production of saliva. What's lacrimation?
Tears.
Tears. Urination, digestion, defecation. Another very classic one are the big 3Ds, the big 3 decreases. Parasympathetic activation decreases heart rate, decreases the airways, and decreases the size of the pupils. I have a former student who is a nurse now. She went through the nursing, she went through A&P 30 and 31 with me, did the nursing program at AR, and that's exactly where I was going. She lives, she has a cabin up by Tahoe. And her and her boyfriend often go up there and will spend the weekends up there. And in the 2 semesters I had her in my class, EMTs had to be called out to their cabin 3 times. And the reason it had to be called out 3 times is because on 3 different occasions, what her boyfriend liked to do was walk around out in the woods and find wild mushrooms and eat them. And on 3 different occasions, he ate the wrong types of mushrooms. And what those mushrooms do is they stimulate the parasympathetic nervous system. So you eat a mushroom and suddenly your heart rate is decreasing, your airways are constricting, your pupils get tiny as a result of it. Again, these must be delicious mushrooms if it's happened 3 times while he was doing that, and yet 3 times in the year that I knew her, this occurred from them, from those 3 decreases. So yeah, it's often, like I said, poisoning, it becomes a reason as well. There you go, exactly. Remember, as we talked about, parasympathetic plays a role in arousal. So another mnemonic, if you don't like rest and digest, is feed, breed, and grieve, right? Digestive function, reproductive function, and grieve refers to the tears, the lacrimation that is caused. And again, your book's got a nice table that shows all these physiological effects. All right. Questions on that? All right. We're good on time. The last thing that I want to do for today is to remember, as we talked about, here we see on the bottom are generic autonomic pathways. But as I hinted at, there are some dramatic differences between our sympathetic and our parasympathetic. And so we want to talk about those. Again, both consist of 2 motor neurons. Both have a preganglionic and a postganglionic neuron. But they're different in where they're located in the body. They're different in how they branch. And they're different in the neurotransmitters they release. So let's go back to our drawings and draw this one more time. Let's talk about the differences between our sympathetic pathway versus our parasympathetic pathway. Now remember, one of the things we talked about our sympathetic pathway is, remember, it's going to give us big global effects. We want big global effects. Now, obviously, there are some things that we already know is going to be the case. We already know we are starting here in the central nervous system. And what part of the spinal cord, for instance, might we find this? Come on, I know you know.
The white and gray ramus. Oh, that's the dorsal.
Right. Where are we going to find our preganglionic neuron?
Lateral gray horn.
Lateral gray horn. Absolutely. Excellent. And what are our effectors again?
Smooth muscle, cardiac muscle gland.
Excellent. Perfect. So we know that is going to be the case. There, excellent. We also know we have two neurons. The first neuron is our preganglionic. And as we know, there are several things we know about it. We know it's axon myelinated or unmyelinated.
Myelinated.
We know our preganglionic neuron starts in the central nervous system and goes to where? Where does it synapse? So again, it starts in the central nervous system.
Autonomic ganglion?
Excellent. And it synapses on an autonomic ganglion. In this case, it's going to be a sympathetic ganglion. But you're right, that makes it autonomic. Its axon is myelinated. What neurotransmitter did we say it was going to release?
Norepinephrine?
Preganglionic?
Just kidding.
Acetylcholine.
Acetylcholine.
Acetylcholine, excellent. Always releases acetylcholine, and remember, it's always excitatory. Oops. Perfect. But here's one last piece of information we need to know about our preganglionic neurons and our sympathetic pathway. Actually, I lied. There's two things we need to know. The first is that, as it turns out, our sympathetic ganglia are close to the central nervous system. So our sympathetic ganglia are ganglia, plural, are close to the central nervous system. So if it's closer to the central nervous system than to the effectors, what do you think the relative length of our preganglionic neurons' axons are? Are they going to be shorter or are they going to be longer?
Shorter?
Shorter. So it's going to be shorter axons. But remember, to have a big global effect, it is going to form many synapses. And to do that, it has to branch elaborately. So this preganglionic neuron, starting in our lateral gray horn, multipolar as we know, out the ventral root to the ganglion, but it doesn't just form one synapse, it forms many, many synapses. It is very elaborately branching, forming many, many synapses, so we get a big, huge, massive global effect. Oops, and we need to myelinate its axons. There. Now, we know it releases acetylcholine. We know that acetylcholine is excitatory. It synapses on many postganglionic neurons. We will just draw one. We know it is also multipolar because it's a motor neuron after all. And there are many things we know about this postganglionic neuron. It starts in the ganglion and it synapses at the effector. What do we know about its axon?
Non-myelinated.
Unmyelinated. Axon. And here in our sympathetic, most of our postganglionic neurons release norepinephrine. But there are a few that release acetylcholine. And as we know, this can be either excitatory or inhibitory, depending on the effector. Now, since our postganglionic neuron starts in the sympathetic ganglion, which is much closer to the central nervous system, it has relatively longer axons. But we still want big global effects, so it is still going to form many synapses, and it is going to branch elaborately. So it just doesn't form one, but it forms many, 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 many synapses, where it can release most norepinephrine and can be excitatory or inhibitory. All right. Questions on that? All right, then let's do our parasympathetic pathway. For our parasympathetic pathway, instead, we have discrete local effects. All right? When you are sitting with that loved one at Ruth Chris because you've escaped your children for a night out of being grown-ups, and they bring you that beautiful steak with that herb butter just melting on top, you salivate as a result of that. Do you start tearing at the same time? Do you defecate at the same time that you salivate? No. You may cry when they bring you the bill at the end of the night, right? But you're not going to cry just from the steak, from seeing the steak. With our parasympathetic, we are having local, focal, discrete reactions. And we see that local control two ways. We are still starting in our central nervous system. We still need to get to our effectors. Our effectors are still going to be smooth muscle, cardiac muscle, and glands. And we still are going to use two neurons. Our first neuron is still the preganglionic neuron. It still starts in the central nervous system, and it still synapses in the sympathetic ganglion. Its axon is still myelinated, and it still always releases acetylcholine, which is always excitatory. Again, notice those three characteristics are identical in both the sympathetic and the parasympathetic pathways. What is different is the location of the parasympathetic ganglia. Parasympathetic ganglia, and I'm going to need a little bit more space to do this. Parasympathetic ganglia are either very close to or actually inside the effector. The ganglion in the parasympathetic pathway could actually be in the wall of the organ. For instance, in the stomach, it is in the wall of the organ. In the heart, it is in the wall of the heart. Sometimes it's just outside, sometimes it's actually inside. So they are very, very close to the effector they're going to innervate, which makes sense. That gives us much more focal, much more local control. And so if you think of our preganglionic axon, with that preganglionic axon, it's going to have a much longer axon and a very local control. So only a few synapses and just discrete branching. So we still have a cell whose cell body is located in the lateral gray horn. It's still multipolar. Its axon still comes out the ventral root, but now it has to travel much, much further before it synapses. And it is only going to form very discrete innervation. And of course, let's not forget to myelinate it. Notice it still always is releasing acetylcholine, and that acetylcholine is always excitatory. And of course, it synapses. On our post-ganglionic neuron. Again, we know a lot about our post-ganglionic neuron. We know it starts in the ganglion and it synapses on the effector. We know it's unmyelinated axon. Right? Those are all still true. But here are the differences. In this case, with our, oh, hold on, I don't want that to stay black. Here, in our parasympathetic pathway, all of our postganglionic neurons release acetylcholine. Now again, some are going to be excitatory and some are going to be inhibitory. That's not going to be different. That part's going to be the same. But notice up here, most release norepinephrine and only a few released acetylcholine, whereas here, all release acetylcholine. So all of these release acetylcholine. And again, some will be excitatory and some will be inhibitory. And notice the other big difference is that short axon and few synapses, discrete branching. Again, giving us a very local, a very focal effect.
So why do some people like to eat when they're stressed if eating is a parasympathetic function?
So,
Like I'm doing it right now.
so here's what I would say to that. Control of the digestive system is a parasympathetic responsibility. How we respond to stressors in our life have a much more top-down psychological type of involvement in it. We haven't talked about it yet because we haven't gotten to the endocrine system. But one of the things that we learned, I don't know, 10, 20 years ago, something like that, 20, 25 years ago, was that our adipose tissue produces a hormone called leptin. And leptin basically triggers the part of your brain that makes you hungry. And basically what happens is it depresses that hunger sensation, so it makes you feel sated, it makes you feel full. At the time, pharmacological companies thought that they had reached the gold mine. Here we had finally a pill that we could give to people. People would take that pill, they would feel full, everybody would be thin and beautiful, and they would be rich. So why aren't we all beautiful? Why aren't they all rich? Because it turns out hunger has almost no influence on when we eat. You ate this morning because I gave you a 15-minute break in between parts of my lecture. Or you ate because you were cleaning up the dishes from when your kids are, or whatever it was, or you ate because you're stressed, or any number of other things. There's so many other factors that influence when and why we eat that hunger and digestive function really have little to do with it. And so, yes, in many instances, hunger can be, biting the nails can be, again, part of that mobilizing resources, right? Part of ingesting food would be to mobilize resources from a evolutionary standpoint to get us ready for that fight or flight response. So it could be related to that somehow. Yep. And I guess you have to bite the nails if you don't have other food around. But yes, so unfortunately, hunger and digestive function really don't drive our eating, right, influences, right? We eat our emotions, we eat our stress. We eat so we have things in our mouth so we don't have to talk to our kids, right? There's all sorts of reasons why we eat. All right. Yes, emotions are indeed delicious. Excellent. So here's my pretty pictures of this. Let's look at the pretty pictures from your textbook. Notice here is our sympathetic pathway. Ganglion is closer to the central nervous system than the effectors. Big, huge, elaborate branching forming many synapses. And while all of our preganglionic neurons release acetylcholine, most of our postganglionic neurons release norepinephrine. But there are a few that release acetylcholine. Here with our parasympathetic, the autonomic ganglion is much closer to the effector, much more discrete branching, many fewer synapses formed. And notice both the pre and the post-ganglionic neurons both release acetylcholine and only acetylcholine. And notice again, if we go back to this picture from your textbook, notice it shows that same thing. Notice with our sympathetic, the ganglion is closer to the central nervous system. In the parasympathetic, our ganglion is closer to the effector. Here, most release norepinephrine. Here, we release acetylcholine. And then notice also, and we'll talk about the adrenal gland. In our sympathetic, we can stimulate the adrenal gland to release that adrenaline, to release that noradrenaline into the blood, giving us that long-lasting global stress response. All right, because that's the other thing too. Once the adrenaline gets into your blood, where can that adrenaline go?
Everywhere.
Everywhere. Again, the ultimate big global stress response. All right, that is all I want to cover today, except to first show you this. Because I want you to see it and I want you to be terrified. What you see here is this big, huge, scary looking octopus type structure that on the surface makes absolutely no sense. However, as we spend more time with this, and by we, I mean you over the next 5 days, because you need to be looking at this, you will see that this tells you pretty much everything we need to know about the autonomic nervous system in a lot of really great detail. Notice what we know already. If you look closely, here we have our sympathetic and our parasympathetic. And notice when we think in terms of effectors, things like the heart, things like the lungs receive dual innervation from both sympathetic and parasympathetic. But notice skin, not over here on the parasympathetic. Adrenal gland, not over here on the parasympathetic. So we see that as well. Notice also when we look closely, we see that to get from central nervous system to effector, there are two neurons, a dark neuron and a light neuron. A dark neuron and a light neuron. Notice the dark neuron would be our preganglionic neuron going from central nervous system to a ganglion where it's synapses. And notice these ganglion on the sympathetic side are closer to the central nervous system. Then it travels to the effector. Whereas on the parasympathetic side, notice the synapse is right next to, or in some cases, even inside of the organ. So we have a much longer preganglionic neuron and a much shorter postganglionic neuron. Notice all the interconnections here. If I'm trying to get to the heart, notice there's many routes I could take to get there. Whereas here, there's really only one route to the heart, only one route to our salivary glands and so forth. So it shows that discretion, it shows the location of the ganglion, it actually shows a lot of detail. And there are some even better ones as well, like this one here. So what we are going to do is we are actually going to look at the anatomy, look at the pathways in both the sympathetic and the parasympathetic nervous systems. We are going to learn the pathways, and I guarantee there will be pathway questions on the exam. Guarantee it. What that means is you want to make sure you're looking at this material this weekend. You don't want me presenting these pathway information to you 2 days before the exam and have it be the first time you've seen it. You have the outlines from the textbook, from my lectures that are going to tell you what we cover, but your textbook also does a good job of describing these pathways. So make sure you're reading this information, make sure you're looking at the lectures, make sure you're preparing so that we can hit the ground running on Monday, and prepare for the exam. All right. Any questions on that? All right. That is all the information that I have for today. Good. Trembling's a good thing. Fear inspires effort. So use this fear to your advantage to motivate you to study this material and be successful. There you go. We'll use the energy from all that eating to do work. All right, guys. Have a good day. Have a safe weekend, and I will see you on Monday. Take care.
Professor.